No, vabbè, ma non riuscite a sentire? Ok. Con questo? Ah, in streaming. Bisogna guardare là. Sembra le cose di Ficarra e Picone. Dice, ma siamo sul video. Okay, so just to welcome again you, because yesterday I assume that they welcome you and there was Giuseppe Angilella, the coordinator of the school. You know that this school is divided into humanistic and scientific, you know everything. So our welcome is the welcome by university. So the University of Catania was founded in 1434, so is a quite old university. There are approximately 57,000 students each year in this university. And so we have a department, a mixed department of pediatrics and internal medicine, and we are 7 pediatricians having 5 units divided into general pediatrics, bronchopneumology, oncohematology, neonatology, and then there is a unit of rare diseases of the nervous system, is a spare disease, and we have a metabolic unit. So our welcome is the welcome from the University of Catania. I'm also the Deputy Rector for International Affairs, so this is a double welcome here. And lo stesso, and again, the welcome, quindi il benvenuto è anche a tutti voi per la seconda volta, so for the second time. So I speak English, so that you can follow. I must look there for the streaming. And so our welcome is to the city of Catania and to the University of Catania. Hopefully there will be time in the future for you to come again, and hopefully you had time to visit and to look around in Catania. At the end of the day, we will tell you again the legend. Can we tell you the legend of our elephant in the main square? Not now, at the end. And so I don't know if you had the time to go to the Dome Square in the city center, okay? Or you will do it, okay? So as soon as I will tell you the legend, maybe you will not go to the square. Comunque grazie anche a tutti voi per essere venuti veramente di cuore. Questa è una bellissima possibilità per tutti voi e per tutti noi. We know that by having all residents, but you know better than me, by having residents in all of our units, we generally tend to grow. As professors and as physicians, you know better than me. So noi siamo molto felici che ci sia questo interscambio e che le nostre unità operative, come in tutta Italia, siano con voi, perché è vero, noi cresciamo assieme a voi e dovunque, come abbiamo detto tante volte con tutti i nostri colleghi, noi possiamo avere, so we can have residents in all the units. The units generally change, cambiano completamente il loro aspetto e quindi siamo molto contenti. La nostra scuola, our school, our postgraduate training school in pediatrics currently have 18 plus 2, approximately 20 residents per year per 5 years. So approximately the number is now in between 75 and 100 residents. It depends on pregnancies, on many variables. So io non voglio perdere tempo, so thank you very much to all of you. Grazie moltissimo anche ai nostri ospiti, alle nostre persone italiane. Voi conoscevate, did you know Raffaele or not? But yesterday you could know, no, yeah, you knew him, okay. Voi lo conoscevate pure, lui è un vulcano, come il vulcano del Mount Etna, and so io lo ringrazio moltissimo per tutto quello che ha fatto. Chiedo scusa per ieri, I do apologize because I was in Rome, and my flight was delayed. So approximately at 1 o'clock I was in the plane, still in the plane. I brought you a couple of notes. And when I landed, I was really the only person in the airport, and there were no taxis, nothing. My family was sleeping, and so I was slightly worried. However, at 3 o'clock I came back home. So, a few hours ago. So, grazie veramente a tutti, benvenuti e cominciamo il lavoro. Molte grazie.
All right, we want to reiterate, thank you very much for hosting us. I'm Elizabeth Sanso, pediatric emergency medicine physician at the Children's Hospital of Philadelphia. We have Dr. Mark Berg from Stanford and Alan, our Canadian representative, both leaders in the American Heart Association. And I am just, yesterday was such an honor. We couldn't stop talking about how brilliant you all are, and not just brilliant, but engaged, interested, enthusiastic, warm, and welcoming. So it makes me emotional because it's such an honor to be here. And honestly, I'm learning more being here, teaching, than I'm teaching, I think. So I really, really want to extend a warm welcome to you all to come visit us in the United States in the future. Already we've had some discussions. But I really would like to continue this relationship, and I would love to exchange information and then see you all in Latina very soon. We are excited to have one more day together to work together. We're going to actually, our agenda, do you want me to go over the agenda for today? So the agenda will be cut a little short, so we understand, hopefully you all had fun last night. I heard a lot of music and I thought if I were you, I would probably be there. So thank you for being here, stay hydrated. We actually are going to, really, stay high. I saw a lot of people at the vending machines and they weren't quite working, so we need to figure out how to get water for people. But we're going to start in 9 minutes at 10 o'clock. Go from 10 to 11 with a 1 hour session. Then we're going, right? Sorry. Yeah, 10 to 11. 11 to 11:30, we have coffee. All right? Can you make it to 11? Okay, because we probably could change it if you can't. Okay. 11 to 11:30, we're having coffee. And then 11:30 to 12:30, another 1 hour session. And then 12:30 to 1:30 lunch. And then we finish. Okay? Any questions about that agenda? Yeah, see. Domande. Oh, sorry, I missed the plenary. And then the plenary. And then we are also going to do a plenary before lunch.
We need
Yeah.
to take a photo before.
Oh, okay.
Because
Okay. Let me. So, and someone asked for an update on the CPR, the PALS guidelines. We are going to provide an update on that too. So actually, we're going to extend lunch, if that's okay. So we're going to do 10 to 11 session 1, 11 to 11:30 coffee, 11:30 to 12:30 session 2, 12:30 to 1:30 or 1, 12:30 to 1:30 back here. Okay, far too early for lunch. Silly me. That was a very North American thing to say. So 12:30 to 1:30 here for the update on the PALS. Okay. Then we take a photo, very importantly. You have to stay because we need to do a photo. Then we have lunch, okay? After lunch, we are 100% here to talk about any questions you have on the algorithms, about other questions you have that you're anticipating for the games. We are here to talk to you all about that at lunch and after lunch, okay? Okay. Andiamo, grazie. recorded, okay? So it's, I want to reiterate, I am here during lunch and after lunch to just review anything again, okay? Possiamo parlare, parlo in italiano anche, okay? Okay? All right. Are we still waiting for people in your group? Because we could just get started if, it's silly to wait if we're all here. We're still waiting? Okay, no, that's, yeah. Yeah, 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 yeah. Their alarms didn't go off. How did yesterday go? Come è andato ieri? Bene? Yeah? You did, what stations did you do yesterday? Did you? Uh-huh. Oh, good, the big ones. Yeah. Okay. So today, respiratory and then neurology. Okay, with Raffaele. Okay, okay. That's a good order to go in. Really paying attention the first day. Yeah, that's good. And what year of residency are you in? Third. Fourth. Okay. Oh, you're almost. Oh, whoa, that's exciting. Yeah. What year? Four. Third. Four. First. Okay. Oh, second. Yeah, yeah. Oh, fifth. Are you doing a specialty or? In November. Oh, where are you going to go? Oh, stupid question. Forget I asked you that. I hate it when people ask me that question. Third. Okay. Four. Okay. All right. Nice mix. Excellent. Well, I'm going to get started because there's a lot to cover. Okay. Yeah. Let's get started. Can you hear me okay in the back? So. What about if how are we, you know, the air conditioning is kind of loud, but I want you to be comfortable. Does that make any difference? No? Keep it closed? I know, it's like, what about, do you want me to turn this off? Or do you want me to keep it on? È meglio così, o meglio così? Okay, yeah. Oh, great, come up. And you do not need to take notes. I mean, sometimes I know I can pay attention more if I'm writing. Only do that if you need to pay attention. I share all of this with you, and I wrote down every single word that I say on the slide, so you can read it while I say it, and then you can have it afterwards. Okay? All right. So only take notes if you feel like you need to pay attention. Okay. So you all know me, Elizabeth Sanso. I come from here. I work at the Children's Hospital of Philadelphia in Pennsylvania, but I'm from California. I went to college here. I went to residency in Washington. I worked in the middle of nowhere, Alaska for 5 years. So I'm someone who, I love to teach PALS because wherever you work, whatever the setting is, I think it can be incredibly helpful. Obviously, today we're teaching PALS for like in hospital where you have a lot of resources and a lot of people around, but you can adapt this to just be working 2 people in the middle of nowhere and have it still be useful, okay? So I understand and speak a little Italian. We have 1 hour right now, so we will not be able to engage in a lot of discussion, unfortunately, but like I say, I am here at lunch, after lunch, to engage in more conversation, and again, no need to take notes. So we're going to be talking about respiratory distress today, and it's one of the most common presenting signs of illness in a pediatric patient, as you all know, okay? You can have both respiratory distress and pulmonary issues and non-pulmonary issues. And non-pulmonary issue examples would be when you have sepsis, heart failure, and metabolic acidosis for a reason. Pediatric cardiac arrest, the most common cause of them are prolonged respiratory failure states that go unnoticed and then progress to cardiac arrest. So you recognize respiratory distress, failure, treat it, you can prevent the whole side of the algorithm where you have to do chest compressions, okay? So very important topic, as you all know. Today we're going to be talking about recognizing signs of respiratory distress, what is respiratory failure and how to treat it, and explain different treatment options, and of course we're going to be focusing on the PALS algorithm so that you're best prepared for Latina in September. So you all know this respiratory emergency chart very well. We will be going through each of the sections today with some cases. We will be focusing on the middle, on the right part of this PALS systemic approach algorithm. We will not be doing chest compressions or looking at EKGs in the next hour. So I really want to focus on the PALS evaluate, identify, and intervene schema, okay? So this is helpful for simulation. It's also helpful for real life, seeing real life patients. It takes some practice to get into this way of thinking, so we'll practice this way of thinking for the next hour. But I'll present some patients, and I ask you all to actively participate and tell me, given this case, what would be your initial assessment for this patient? Then after the initial assessment, you identify what you think is going on in an initial intervention before you get to your primary assessment. Your primary assessment is your A, B, C, D, E, okay? Then after you get through your A, B, C, D, E, what is your identifying the situation at this point, intervention at this point, before you get to your secondary assessment, which is really where you get at the history to diagnose the patient. So that is your sample history, your re-examination after your initial primary assessment interventions, and then you identify at that point, I think this is asthma. I really want to treat with steroids and albuterol, and then here's what I want to do to monitor the patient, okay? So it's a little, who feels comfortable with this way of talking about a patient at this point? Very few people do, but I think with a little practice over the next hour, it'll feel more comfortable, okay? Yes, yeah. Absolutely. Good morning, Giorno.
When you do ABC, sometimes you have to stop the B because the problem is there. And maybe there is also other notions with the E, exposure and so on. And so you cannot know it before. For example, the temperature, if it's high, you still have not spoken with the mother. You don't know if she gave some medicament, some paracetamol, and you give it again. So maybe there is just a few hours between the two subministrations. So sometimes the order is good, but sometimes you see that it's...
Very good question. Yeah, we're talking about, this can feel like it's a lot of steps and like it takes a long time, and you want to do everything at once. And trust me, I know that feeling. Actually, the initial assessment and the primary assessment is going to happen in about 2 minutes. And it's okay to hold off on the Tylenol for the 2 minutes. And I know that feeling of having it all in my brain and wanting all of the information right now, like a test question, and I want to write down everything. That's part of learning how to be in a simulation resuscitation or real life resuscitation is, okay, let's really do our ABCD quickly. Intervene for the life-saving things, airway, breathing, circulation, quickly. Forget about the Tylenol right now, And then, once we have our airway, breathing, circulation down, secondary. Okay, that includes our meds. You got Tylenol an hour ago. Let's not give you Tylenol quite yet. Let's give you Motrin or ibuprofen or nothing, and it's okay to wait. Okay. They could have a, lethal allergy to Tylenol or something, so exactly. But I know the feeling. Yeah, it's a very good question, and that question comes up in every session. Okay. Other questions?
You're talking about evaluation after intervene. So I do something weak, I go with the CDE to evaluate. Do you think it's better at the end of the E before the secondary evaluation or endpoint, or you start the secondary assessment at the endpoint and then you go back in B to see if albuterol makes something on this child?
So I say as the leader, okay, I need a primary assessment. My survey physician and my airway physician. My survey physician is the one who's telling me if the airway's open, if I hear breath sounds, if I feel good pulses, if I feel good capillary refill, is the patient alert or not, and what the temperature is, okay? And we're getting a set of vital signs, okay, at that. And then I say, okay, that'll happen, in 30 seconds, 30 seconds. And then I say, okay, we have, we have an open airway, but we have respiratory distress with a lot of wheezing on auscultation. We have good pulses and good cap refill and a very alert patient. I think that this is asthma. My differential includes other things, but for right now, before the secondary assessment, I would like to start some albuterol, some oxygen if the saturation is low. And then while we get that started, I would like to ask the parent a little more history and go like that. Okay, so you're like, primary assessment, A, B, C, D, life-threatening things. Do we need to open the airway? Do we need to give any oxygen? Do we need to put an IV in and give some fluids immediately? Or can we kind of stop and regroup or not? So I think that's a nice stopping point from the primary to the secondary. And then your secondary, before you get it started, you get the albuterol and the oxygen started, and then you get the sample history. And as you're getting the sample history, then you get another evaluation. So, you know, the albuterol has been started, the oxygen's been started, you get a new set of vital signs, and you get a new exam. You ask your survey and your airway doc to tell you the exam again. You realize, okay, the work of breathing's improving, the saturations come up, you still have good pulses, good cap refill, the patient's, you know, even more alert. And you're like, okay, I think this was like, you know, simple asthma, you know, we'll give some steroids, we'll monitor for 4 hours. Does that answer your question?
Yes.
Yeah, yeah.
And another question is the timing of interpreting. So if I, on the situation, I have wheezing, it's better to have A, B, C, D, E and do albuterol and not write in B because I don't have an idea of the A, B, C, D, E with these. Sometimes
right.
I see people, okay, wheezing, albuterol, then go C, then C, shock, ring the it's kind of...
Right, like really, am I supposed to say A, stop, talk about it, then B, stop, talk about it, C, or do A, B, C, D, and then talk about it? I say A, B, C, D, and talk about it, because you have multiple people in your team, okay? So if your airway's not open and they're not talking to you, you're gonna be doing everything possible to open the airway before you do anything else, okay? But otherwise, your airway, breathing, circulation, D, they all go together because you need to know if they have increased work of breathing and wheezing and have terrible thready pulses and they're totally pale, because at the same time you have teammates who one person's going to put oxygen and start albuterol on the patient and maybe call to get a BiPAP machine if they look really bad, while the other person's going to work on your access. They're going to be trying to get an IV because you're thinking this is now shock, right? If they have really poor perfusion, you got your D, they're lethargic, they're not alert. You need to be doing an IV and getting the albuterol going at once, not just being like, I have wheeze, can we order the albuterol someone? You're delaying time. And it really takes an extra 1 second. The primary assessment happens fast, okay? Airway, patent, breathing, breath sounds, wheezing on the right, nothing on the left. Circulation, I feel a pulse, I don't feel a pulse. You know, it happens fast. So I think, and then you can say, okay, this is respiratory distress. This is actually failure, and we'll go through the difference now. This is shock, you know, and it's good to say that from the initial assessment to do your life-saving interventions fast, rather than waiting for someone to say, how much albuterol do you want? Like, you should be probably getting IV fast. Does that make sense? Yeah. Okay.
If there is a low saturation during the ABC,
Yeah. Yes, so what you're gonna see is you're gonna show up with your team, right? And you're gonna show up with the group and immediately say, I'm lead, you're airway, you're a survey physician, you're doing the exam, you're getting the IV, you're working on access, you're getting medications, you're recording, you know? And if we need CPR, you're doing your CPR. And then they have to do that first. You have to, before you have to get people in order. And then you, as you're getting the patient attached to the monitors and getting a set of vital signs, so that can be someone's role to attach the monitors, get the pulse ox, and that's, you know, always delayed, to grab it, attach it, put on the cardiac monitors. Hopefully there's someone who's actually taking some vital signs. There's someone doing that while there's another person doing the exam. So, and the person doing the exam needs to get in there around the person putting on the monitors, and they need to say airway, they need to say it loud and clear because they're the only one touching the patient. Airway, clear. Breath sounds, I hear good breath sounds, right, left. Pulse, I'm feeling a radial pulse, feels good on both wrists. You know, and just going down like that. as you're saying, and then beep, 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 you're starting to get the saturations around that point. You know, this is kind of the reality of how it goes. And then you're like, oh wait, the patient looks like, now with a good waveform, that their saturation is 80% on room air. By that point, your survey doctor is probably already down at D. You say, airway, do you mind grabbing nasal cannula and starting the patient on some nasal cannula, or at least blow by, or setting up a face mask? We need to address the hypoxemia. Okay, so it really happens at the same time. And that's why I really want to, you're not going to learn how to do this right now in the next hour. This is very much an introduction, and you can go back and look at these. You're going to get it when you start to do it, when you do it in simulation, and when you go back to residency. I beg of you, go to the fire, meaning there's a sick patient, you are there, okay? Go, go, go. That's when you're really going to start to see how this happens. And you're going to see this process happen really well with some teams, and you're going to see it not happen very well with some teams, and you're going to learn so much from both ways, okay? Is everything okay with the, okay. So, very good. So the primary assessment, and I really want to spend time talking about the respiratory, but this was really to prepare you for PALS, and I felt like this is equally as important as the respiratory, because I think you know the respiratory. So the initial assessment is this pediatric assessment triangle, where you look at the appearance, the breathing, and the circulation, and then you get the vital signs, okay? And then this will be, yes. Yes.
What kind of sounds make this patient? Has a trigger?
So it actually, this is your look from the door, and you can absolutely see stridor from the door, but you want to just know, are they alert, are they not alert? Are they breathing, are they in distress, or not, like totally not a respiratory thing? Do they look totally pale and like, just completely like not responsive? That would be, you'd want to know that as we're getting vital signs, okay? Really the stridor, obviously you can see the stridor from the door. You can say stridor, you can also just say respiratory distress. I think it's stridor. Let's go through our ABCDs. Then you get to the ABCDs and it's obviously stridor, okay? This is like a very, from the door, they look distressed. I should go into that room and not go to the bathroom right now. That's what this is, okay? But you're not diagnosing croup with your initial, yeah, exactly. So, speaking of which, here's our first case. So, we have a 9-month-old infant who had 2 days of cold symptoms, who comes in with sudden onset, loud, noisy breathing, okay? Your initial PAT, your assessment triangle, here you get your set of vital signs really fast. The heart rate is 140, blood pressure is 86/58, breathing at 48 breaths a minute, oxygen saturation's 89% on room air, and temperature is 38. The ABC, the appearance, breathing, circulation from the PAT, they're crying. Fussy is like irritable, crying a lot, and the parent is holding the baby, trying to calm them down. They're breathing fast, they have increased work of breathing, they're using, and you can see the occasional stridor from the door, and they look pale. At this point, what do you identify, and what do you want to do immediately? Mm-hmm. Exactly. Respiratory distress, you want to pay attention, and you probably want to maybe start talking to your airway person about some oxygen. Boom. Exactly. Oh, and get your monitors on if that didn't happen with your vital signs, okay? So for PALS, that's all you want to know on the initial PAT. Distress, fine. They're in respiratory distress, you put on the monitors, and you want to continue. So now, what do you want to go on to after that initial PAT? The primary assessment, which is A, B, C, D. Yep, okay, very good. So your ABs, you have an unobstructed, but noisy, stridulous breath sounds. The baby is breathing fast, using all of their retractions to breathe. The saturation has come up to 98% on some nasal cannula. Their circulation looks pretty good. Skin is well perfused, strong pulses. They're awake. They're alert, but they're very irritable, but they are consolable. So the parent is able to calm the baby. And on lung sounds, you do notice that there's stridor when they're at rest too, okay? So the mom is able to console this baby, but they're still at rest. You notice, and they're pulling in right there, even just totally calm. Temperature is 38, here's their weight. At this point, after the primary assessment, what do you want to identify and how do you want to intervene before you go on to your secondary assessment?
This is an upper airway obstruction syndrome. Respiratory distress symptoms.
Yep. I agree. We're thinking this is now respiratory distress and it looks like upper airway obstruction. Perfect.
Many differential diagnoses I have in mind,
Mm.
but straight to the ABC and correction. So,
Perfect.
stabilize the airway. I say to my
Mhm.
airway
Oh. Okay, so you're talking about stabilizing the airway, you want to open the airway, and you want to make some interventions on ABC. Okay, so I totally agree. Respiratory distress, this looks like upper airway obstruction with the stridor. You saw the hypoxia, the nasal cannula helps, so you want to continue with the oxygen. And very importantly, with these croup babies, and you're going to see them a lot in your career, it's very important to keep them very comfortable. So I actually, with these patients, I don't go doing anything that I think is going to make them mad. This is very unique to this upper respiratory. You really want them to be as comfortable as possible. So keeping them comfortable in the parent's arms is typically your best move. Not going to try to get an IV if they don't look like they're in shock, and really trying that first intervention for the upper airway obstruction, which would be some nebulized epinephrine or racemic epinephrine, depending on where you work, okay? That can really help open up the upper airway, all right? Has anyone seen a patient with croup or an upper airway obstruction before? Okay, and have you seen this patient with stridor at rest? Like can you picture this patient? Okay, very good. So I do always reiterate, trying to keep them calm. Let's see if the nebulized epinephrine works, and let's keep a broad differential. Very, very good. So then you go on to your secondary assessment, right? Now you're gonna get the diagnosis. So you're thinking broad differential diagnosis in your head. Now you're gonna use your history in your exam to really focus in and say, my leading diagnosis is this. Still thinking about these things. Here's what we're gonna do based on my leading diagnosis, and then we're gonna reevaluate, okay? So, your sample history, they awoke suddenly, it always happens in the middle of the night with a barking cough, respiratory distress, they've had fever for 2 days. No, now you're getting no allergies, whew, the medications, oh, they did take some Tylenol for fever. They've had already, this poor baby's had 2 ear infections in his little life, ate okay two hours ago, 2 days of cold symptoms, and here are the vital signs. Heart rate's 158, breathing now 32 breaths per minute, satting 99% on that nasal cannula, blood pressure is here. They still have some mild nasal flaring after the racemic epinephrine was going, still have some nasal discharge, but the stridor is only present now with agitation. So you gave them the inhaled epinephrine. When they're crying, but when they're at rest, you don't hear it anymore, okay? And they're consolable. So at this point, you've trialed the first medication and you have your reassessment. What would you, at this point now, after the secondary assessment, identify and then say your plan moving forward? So you've done the primary assessment, and exactly, you're always reassessing, but you've now, so you're identified, yeah, yeah. Right. Yeah.
So maybe you give some cortisone.
Love it. Love it. So, and then and this is always the leap that residents are always pushed to make. You got to make the leap. So now you have to say, I think this is, what do you think the diagnosis is? Croup. That step is a big step, right? Because you're like, the patient's improving, the respiratory. I think this is croup, because they came in with this, I'm just gonna be bold and say it, you know. Later I'm gonna say what else it could be. But I think this is croup, you know, they have a fever, they've had 2 days of cold symptoms. We gave them the racemic epinephrine, it helped. Because it's croup, I wanna give them a dose of steroids. and I want to watch them for 2 hours for a rebound effect, to see if that racemic epinephrine wears off. I don't want them to be home for that. I want them to be here for that. After 2 hours, if they still look great, they can go home. If not, we'll talk about other things. My differential includes, things we're watching for, my differential includes, and what would be other signs of upper airway obstruction? Epiglottitis, okay. Very good. Yep. Foreign body, very good. Yeah, I mean, but sudden onset, I've missed foreign bodies. They have a fever, they've had cold symptoms. I mean, every kid has cold symptoms, right? I've missed it, So very good. More common in your toddler who's putting Legos in their mouth, but absolutely. And then hi, welcome, no worries. And then on the respiratory distress, there's lots of things, and we can go over the things that can cause upper respiratory, but there's one other major category on the PALS flowchart. Do you remember which one that is? That one's anaphylaxis. So, and of course the baby doesn't have hives, doesn't have a swollen tongue or lips, doesn't have wheezing, isn't vomiting, it doesn't have the other signs of anaphylaxis, but something to consider and making sure that you're documenting and talking about really well, okay?
In this case, at the beginning, it's not correct to put ED line, but still the patient could, how can I say?
Yeah.
I mean,
Could get worse. Yeah. Yeah. Very good. Yeah. Yes. And this is a very, 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 I would have asked the same exact question if I were you. You're like, they're in distress. Are we going to need access, right? With this specific patient, with the circulation so good, the mental status very significantly here is the parent was able to calm them down. And they were hypoxic, but not so hypoxic. 80, 89 came up really quickly. These are patients you actually really don't want to mess with at first. You really want to keep them comfortable. You're going to see thousands of these patients, and you're going to learn from your patients, not from me right now. But this is a patient, it's hard to describe, it would be better on a video, but this is a patient who, but I'm telling you the tangible things that you're reading that make you feel like, okay, they're not lethargic, their circulation's good, we really just have one side of that triangle that is not so great, but it's coming up with some oxygen. I want to try this one intervention because I know in a crooper, if I make them really mad, they could get really worse. So I just want to start the racemic epinephrine first. I'm ready, my person's ready, at the patient's right to put in an IV if we need it, if we have a change, and we're reassessing constantly, and if we notice there's a change in the circulation or the disability, or a profound change in the respiratory, we have to put an IV in. But for now with this patient, because there's only one side of the triangle, and knowing this diagnosis can get worse with pain, I'm going to hold off and just give the racemic epinephrine, okay? Mm-hmm. Oh, you know what? You can have them swallow it. There's some that they can swallow. You can swallow dexamethasone. You can do, and then if they throw it up, you can give it intramuscular. Of course, that makes them mad. but yeah, you can do IV, IM, or oral. Yeah. So so what are your oral? Okay. Perfect. Great. Yeah. Perfect. However you get the steroid in, I love it. Yeah.
Because he has a respiratory distress,
Yeah.
was a respiratory failure probably.
Exactly. So here, the very important point was this is distress, not failure. We'll get into the definition right now. Do you know the definition, the difference between distress and failure? You're like, you look bad, you look better, but and we'll get through the definition of that. Okay. All right. So just going over the anatomy, and again, you're going to get these slides. But very importantly, I love that you mentioned epiglottitis. Anything up here can cause upper airway obstruction. You have a problem with your epiglottis, your larynx, your pharynx. You have a foreign body. You have a peritonsillar abscess, or retrofit. Anything up here can cause stridor. So you got to keep your differential broad. Okay. This is an example. This is a nice image. When you start to intubate patients, I really want to bring your attention back to the anatomy, because pediatric patients have a very different anatomy, obviously, than adults. Big floppy tongue, big floppy epiglottis. Larynx is more superior anterior. Intubating is a very different story. So we don't take intubation lightly in pediatric patients, and really the most experienced person in the room should be intubating because they know the difference and they're experienced. And you will get there too, someday. Okay, and then there are different ways that you can use to open up the airway. Have any of you used a nasopharyngeal airway before, or an oropharyngeal airway? You have? With the, oh, and what was the patient that used an oropharyngeal airway in? Do you remember why you used it? Exactly. Bingo. Only unconscious patients. Can't use it if you have a gag reflex. You can imagine why. It's not going to feel very good. You're going to gag. You're going to throw up. And you're going to realize they're not unconscious. So I actually haven't used one in probably 20 years. I used them more in adults than children. But a great option if they're totally unconscious and you want to just put something in to keep the airway open, okay? Nasopharyngeal I use more, especially in those patients maybe who had just had a seizure or received a lot of benzodiazepines, and they really lost all their tone, and they have a big floppy neck is like this and their tongue is like this, and you're really trying to bag them and you're not seeing good chest rise. That's when I really think I have to really open up the airway, and it takes a lot of muscles and hands. Let's get in a nasopharyngeal airway, stick it in. It helps keep an opening that I can breathe through more easily, and that really is helpful in those situations. So you will have these in the PAL stations at Latina. Don't even touch the oropharyngeal unless they're completely unconscious. And the nasopharyngeal is really nice in some of those situations where you cannot bag the patient and you need to have an open airway, okay? Yeah. Yeah, you can, yeah, exactly, yeah. And you see how they tolerate it. Yeah, exactly. Yeah. Awake, not awake. Awake, cannot bag, rarely use. If you're using that, you probably need to talk about intubation if you can. Okay. Okay, so distress is not synonymous with failure, and we've started to get into this. Okay, there's several types of distress, and the etiology and where it is can lead to the proper diagnosis and treatment. You can have distress without actual respiratory disease, so the problem could be non-pulmonary. Certainly you could have a central nervous system issue that's causing your disordered control of breathing. You can have metabolic acidosis. You're creating more carbon dioxide and trying to get rid of it by breathing off fast, but it has nothing to do with your lungs at all. It has something to do with your diabetes, you're in ketoacidosis, or you're in shock. So think about other things when your interventions aren't quite working, and of course you're going to think pulmonary, but really remember those categories on the PALS algorithm, because there are other categories, including the brain, including your metabolic processes, okay? So in respiratory distress, we are going to, for sake of time, I would love to just quick have you guys tell me, when you look at a patient and you're seeing if they're in respiratory distress in a baby, what are the signs that you are seeing? And you've already talked about quite a few of them. And we can just start in the back and come on up. Signs when you look at a baby of respiratory distress on physical exam. Breathing fast. Huh? Tachypnea. Retractions. And where can you have retractions? Jugular? Intercostal? Flaring? Nasal flaring? Perfect. What? Say it again. Oh, what is that? Oh, cyanosis. Thank you. Yeah. And is that an early or late finding? Cyanosis. Very late. You're like, ooh, exactly. We're like, we might have to do chest compressions unless we fix this right now. That's what cyanosis is. What's another late sign of? Oh, hate that. When they're breathing slow, when their heart rate starts to drop, all right? Because respiratory distress causes a stress response, so your heart rate and blood pressure should go high. We expect that, we like that. If your heart rate's going, the monitor goes, beep, 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 ooh, code button, get help really fast, okay? Very good. Any other signs? Noises. Exactly. And a common noise that you would hear other than stridor. Okay, and then this is even without your stethoscope. Okay, grunting. Have you ever heard grunting? Yes. All right. Does someone want to demonstrate grunting? There's always one that feels brave. yeah. Really. Head bobbing. So that's another sign of late. So when I see cyanosis and when I see head bobbing, babies who start to head bob, they're really lethargic at that point, and their muscles are just, ooh. Oh, the thoracoabdominar dissociation, or the seesaw breathing, right? A sign of like lower airway obstruction, like an asthma process, and you're like, that's a really good one. And early, I never really completely had ever seen that. And then once I was with a nurse, and she's like, they're doing the classic seesaw breathing I just saw in my pals, and I was like, what's that? I haven't seen that. And when I was like, well, I'm glad she just said something, because that doesn't look normal, and I guess that's what that is. So you know way more than me at your stage. Seesaw breathing, bad. Also, my lesson here is always listen to the nurses. I cannot reiterate that enough. You have an experienced nurse, listen to them. Yeah. Again? Okay, so here, you said them all. Bravissimi. Okay, so tachypnea, you have too much carbon dioxide. They're trying to breathe off their carbon dioxide. Little babies do that by breathing fast, okay? It's amazing that babies can actually breathe really fast before they even show other signs of respiratory distress. So I really beg of you to always get your own respiratory rate, okay? Because you don't want to miss a baby who's breathing above 60 breaths a minute, like truly, and send them home, because that could be the very beginning of a process, okay? And I can't tell you how many times we've missed it where someone's gone in and measured the respiratory rate in 15 seconds and multiplied it by 4, and babies breathe irregularly. So that could have been the 15 seconds that they were breathing more slowly. You miss it, okay? If you don't, and you can have a very comfortably tachypnic baby, even to 70, 100 breaths a minute. That's an early sign that they're going, because they can't keep that up, right? They're gonna start showing all those signs of distress. So you don't want to miss those. So the most important part of your exam when you examine every baby is count out the breaths yourself, all right? And then really stop and be like, even though they look so great, there's probably not something so great happening. Super important. Your minute, so babies maintain their minute ventilation. The equation is tidal volume times the respiratory rate. But their tidal volume, babies are already functioning at a very high lung capacity, so they really, like adults, really can adjust their tidal volume using their strong intercostal muscles. Babies, less so. So they really rely on the respiratory rate, which is why this is very much a sign for babies and children. Nasal flaring, you talked about, literally, it's like a cool physiologic way that the babies just open up their nose. Before you have that nasal pharyngeal tube, they're doing it with the flaring. Retractions, the collapse of that soft muscle, those soft tissue due to that muscular effort, okay? And like you mentioned, all of those signs of where the retractions are. Little babies have a super soft sternum, and you can actually see sternal retractions due to the cartilaginous sternum in babies too. Grunting, we talked about that, that's the way that they're auto-peeping. They're closing off their glottis, which is a way to increase their positive and expiratory pressure without CPAP. It's their body's way of doing a little CPAP. Seesaw breathing, you talked about. Excellent. And then and you can kind of start, even just looking at the patient, you can kind of, which is exactly what we started the day with first case. You can, if you see those jugular suprasternal retractions and no other retractions, and then you hear the stridor, there's probably an upper respiratory obstruction going on right there. You can also see kind of the nasal flaring and the grunting up there. The head bobbing, late sign in that lethargic baby. So let's go on. So we have about 25 more minutes, and we have 3 more cases. So we'll kind of move these along, and then I invite you as a team to use these cases and practice as teams to go through. Initial assessment, what's our PAT? Primary assessment, how do we identify and intervene? Distress, failure, oxygen monitors, basically. Now, primary assessment after that, ABCD. How do we identify? Most sounds like upper airway obstruction with respiratory distress. I want to start racemic epinephrine and get more information. All right, secondary assessment, sample, repeat the physical exam. Stridor's gone, they look comfortable, they're not hypoxic anymore on the oxygen. Let's keep a broad differential for upper airway obstruction, including anaphylaxis, foreign body, epiglottitis, reevaluate in an hour or two, okay? That's what we're gonna ask you to do for all of the cases for PALS. Does that, yeah, so for this case, we'll kind of quickly do it together as a group. So we have a 10-year-old with respiratory distress. On initial assessment, their heart rate and blood pressure are a little high, they're breathing fast, their oxygen's a little low at 88%. The PAT, they're anxious sitting up in bed, their increased respiratory rate with some retractions, and they look well perfused. So our PAT is, what's our initial identification? Respiratory distress, boom. What do you want to do just immediately before you do primary assessment? Oxygen, love it. We want to get we're in distress. We want to get our oxygen going and attach our monitors, okay? And now we want to go on to our primary assessment. So our ABCD, so they look like they have nasal flaring. There's no stride or upper airway obstruction. They're breathing at 42. They have retractions. They have bilateral, diffuse, expiratory wheezes. No crackles. Their saturations are coming up with the non-rebreather mask nicely. Their heart rate's a little high. They're well perfused. They're anxious, but they are alert. And after speaking for 3 to 4 seconds, they have to stop and take a breath. Here's their temperature, 37. At this point, after your primary assessment, what do you identify and how do you want to intervene before you get to your secondary assessment? Okay, so you're thinking asthma and what? And yeah. Lower airway obstruction. Very good. Okay, and what do you want to do right now before you get into your sample? You want to start salbutamol. Very good. So I'm thinking this is a lower airway obstruction. I hear bilateral wheezing. I'd like to start some salbutamol and then go on to the secondary assessment. Bingo. So that's exactly what I would say. You want to make sure they're comfortable always. They're not in failure, so we don't have to worry about poking them right now with an IV. Assess their response to oxygen. You can start some ipratropium also, depending on where you work. You know, salbutamol is always the right answer for wheeze. And then you can, at this point, administer steroids. It would also be reasonable to do that after the secondary assessment, too. So you wouldn't lose points with me if you said, hold on the steroids. Let's see if they respond first to albuterol, because, you know, this could be non-asthma. There could be other things causing wheeze. Secondary assessment, you get your sample. They have cold symptoms, they've had a cough, they have family members who smoke, they have allergies, they have a history of asthma, they ran out of their inhaler, they've been admitted in the ICU several times for asthma exacerbations. After that salbutamol, they have a lower respiratory rate, better air movement bilaterally, less wheeze, less retractions, and they're more alert, and now they can speak in a full sentence without taking a deep breath. So now, what do we do identify and intervene at this point? What would you say?
It's probably asthma.
Most likely asthma. Great. Severe attack of asthma. Great. Mm-hmm. I love it. Love it. I love it. Yeah. Okay. Okay. Yeah. Yeah. Yep. Yeah. 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 I mean, I love it. Everything you're saying is spot on, perfect. I love it all. You know, I think, and it'll totally depend on where you work. This is a patient who has a lot of warning signs, who's been coming back, and it has proven to get sick fast. So other things you could talk about in the emergency room are, I love it, watch for 2 hours at least. You know, he looks like he's a lot better now. Do I trust him? No, based on this history. Probably give those steroids if you didn't give the steroids already. And then discuss as a group. So this sounds like asthma. He's been sick already. If he gets worse again, which he probably will, here are the other medications we can use at that point. And those medications include magnesium, salbutamol, exactly. So those are the, right. And then also terbutaline and intramuscular epinephrine. And if you're in a pinch and in a place where you don't have other medications, can actually work quite well as well. And then, then you notice that he starts breathing, his work of breathing starts to pick up really, really badly, even though you're giving the magnesium, the terbutaline, the continuous albuterol. What would you want to do? You're calling the ICU, but before they get there, what are you going to try to set up and get started? they're working really hard to breathe. Mhm. Okay. Yeah, I like the way you're thinking. You're thinking, I'm going to need to help the breathing. It's really, really tricky to intubate and extubate an asthmatic. It'll make anyone nervous. If it doesn't make them nervous, you know, find someone else to talk to you about the intubation, because these are tricky ones on ventilators. So I do everything possible to prevent an intubation. You're always like looking at it over there, you know, making sure your intubation stuff's there. But BiPAP, a BiPAP machine can really save these asthmatics, okay? So if I'm thinking, this is a concerning patient, I'm thinking I need to call the ICU, but right now they look fine, but I'm worried, because I thought about calling the ICU, know that feeling, and know you have non-invasive respiratory ways to help your patients way before intubation that can really, that is exactly what they would do in the ICU. So BiPAP, okay? BiPAP for asthmatics if they're working really hard. And you get all that ready, but this patient is fine. You get some steroids, some albuterol, you saved them, okay? So we're in the lower airway obstruction area right here. We've gone through upper airway obstruction, we've gone through lower airway obstruction. Here are all those medications we just discussed for asthma. And then of course, bronchiolitis is your other lower airway obstruction diagnosis on the PALS algorithm. Bronchiolitis is something you have probably already seen or will see a lot of. And the treatment is not asthma, the treatment is suction, suction, suction. And if they have the increased work of breathing, you really want to talk about high flow nasal cannula sooner than later with those patients, okay? Questions on lower airway obstruction? Yes. Yes. Mm-hmm. Yeah. Yeah. Yeah, I read that too, and yeah. Yeah, agree. Suction, high flow nasal cannula. Suction all of the nasal discharge out. Observe them very closely. If they continue to have severe retractions and a severely high respiratory rate, I start high flow nasal cannula. And if that doesn't work, I go on to CPAP, okay? And once I'm starting some CPAP, I'm probably doing an IV also, because they're not gonna be able to drink, okay? Yeah. An IV, so some IV fluids. If you're talking about CPAP, you know, the continuous pod. Yeah. Nasal cannula, so, and I worked in places like that too, yeah. Uh-huh. Okay. Yeah, so a very good point. You know, if they're breathing that fast, it means they're probably not drinking very much. Where I work now, we hold off on the IV. We continue to let them feed without the IV on nasal cannula, but high flow nasal cannula, but that's in a place that you have people who all they do is watch the babies on high flow nasal cannula, and they will come tell you, even if you're not paying attention at all, if that patient's getting worse, okay? Any other situation that I've worked in, I agree, let's get an IV. I'm not paying attention to them all the time. I have other things to do. They, you know, so it's totally where you work in a style thing. And yeah, as long as you're explaining in PALS why you're doing it, it's right, yeah. Okay. Yeah. So in the real life, you know, you're like, oh man, you know, of course wheeze, you can hear wheeze about bronchiolitis and asthma. You know, it's, if you read the books, they say, you know, obviously just pure bronchiolitis does not respond to albuterol. If you're suctioning, if you're starting high flow, and they have a family history of asthma, you know, and you're really noticing that expiratory phase is a little prolonged, so it takes 1 second for them to breathe in, 2 seconds for them to breathe out, and you're noticing that it's just end expiratory wheeze. Those are the ones that I've just like, just try albuterol. And sometimes it really works. And you're like, well, now we know. Yeah. But a little older, definitely, you know, under 2, kind of really hold your hands and but always discuss it, and I guarantee you that ICU is always discussing it too. I love it as soon as I'm like trying to be pure suction, not, you know, little nasal cannula, and I send them up and they like tried albuterol. I was like, so there's real life and then there's the books, and I totally agree with you. Okay. Oh. So failure. Okay, here's our definition of respiratory failure. So inadequate oxygenation and ventilation. You can get this on an arterial blood gas. I've never get arterial blood glasses. Sometimes I get a VBG, but that's only if the PICU asks for it. I'm using my clinical exam, okay? And on clinical exam, you can tell what your pulse oximeter is by putting on the pulse oximeter. And if that's low, you can give them oxygen. Remember that as soon as you give them oxygen, you're masking the hypoxia. So you have to, suddenly that problem hasn't gone away. You need to make sure that you try them off of the oxygen to see if that problem's gone away. Sometimes you just need oxygen for a few minutes. Sometimes you need it for a few days, okay? So remember, when you put on exogenous oxygen, they still might be hypoxic. Ventilation feels really bad. So when you have high CO2, those patients are gonna feel like they're suffocating. They're gonna look at you like, help me, help me, help me. They're gonna be breathing really fast. That's how your clinical exam will show you high CO2 without getting your blood gas, okay? So when you have the oxygenation and ventilation combination, now you're in failure, okay? And on your PAT, that's gonna look like you're not just breathing fast, but you're also gonna be, your mental status, your appearance is gonna look like air hunger. And that's when you're thinking, ooh, we might be in a failure situation right now. And then if you lose your circulation arm also, yeah, you're in failure, okay? So that's clinically how to kind of get at that. So, and we talked about already the stress response, but you should really have tachycardic hypertension, that anxious look, some sweating, and you're really irritable or very unhappy when you have respiratory distress and failure. Some etiologies, so the causes of failure include all of those things that we've already been talking about. So your central nervous system, some sort of process going on in your brain, drugs, so things to really not forget. And these are the ones that are the most important, because what we've talked about so far, the pulmonary ones, they're kind of obvious. You're gonna read them and be like, I know that. Don't forget drugs. Babies get into things, toddlers get into things, toddlers give babies things, people give babies things. So remember, drugs can cause respiratory depression. Opiates can cause pinpoint pupils, respiratory depression, quick fix with some Narcan. Really, you don't want to miss that one, okay? Neuromuscular diseases, abnormalities of the chest wall. Do they have a thoracic dystrophy? What's the history of this patient? So there's lots of reasons why you would have respiratory failure that are not just the lungs. And then of course you have the lungs. And we think about the respiratory system in compartments. So you have your extrathoracic cavity, you have your intrathoracic cavity, and within your intrathoracic cavity, you have your pulmonary and your extrapulmonary part. And so different physical exam findings can help you kind of dictate, even without imaging, a chest x-ray or a CT, kind of where the process is. And you've all been talking about that very nicely. Upper airway, we have stridor. Some lower airway, we have wheeze. We can have some crackles as like parenchymal disease. We can have absence of lung findings with something like a pneumothorax, which would be the pleural space finding, okay? Totally clear breath sounds and they're breathing really fast and they don't have any of those things. Think non-pulmonary etiologies like your central system or an actual musculoskeletal disease. Does that make sense? Okay. And then this is just a schema of all those compartments. So really think, there are compartments. I'm gonna use my exam. If the exam's normal, except for they're just breathing fast, we have an issue outside of this area. And remember, there are other things to think about. And if you forget them, just look at your PALS flowchart and look at the very bottom. All right, so there are 5 causes, and I'm gonna run through these because these are things that I'm gonna say, and either you know them cold already or you're gonna read them and forget them. So they're here on the slides for you to have, okay? But once you've determined that you have respiratory failure, and you look now, is it just hypoxic or hypercarbic, okay? There are 5 causes of hypoxic, okay? So this is where, to be honest, you get into this more in the ICU. In the ER, you're like, give them albuterol, put them on BiPAP, and send them upstairs. And that's when they're teasing out, if they're not getting better, what are the other 5 causes of hypoxic? So here are the causes. Ventilation perfusion mismatch, alveolar hypoventilation, right to left shunting, impaired diffusion, and low inspired FiO2. So the VQ mismatch is that ventilation perfusion mismatch. So you all use the term VQ mismatch, right? Okay. So something that stops the perfusion, like you have a pulmonary embolism. Now you're not getting blood to that ventilated lung, you're gonna have poor VQ mismatch. Something like a mucus plug really interferes with the respiratory part, even though you have good perfusion, you're gonna have poor VQ mismatch. Alveolar hyperventilation, so you really see with these a rise in the CO2, a fall in the oxygen. Causes of hypoventilation include all of these things here, okay? So you can, again, have those central nervous system causes, including things like tumor, trauma, drugs, or problems with your respiratory muscles or your actual pulmonary system, like we discussed. You can get those right to left shunts caused by your cardiac shunts, but also those pulmonary shunts, pneumonia, edema, atelectasis. These are all called right to left shunts. That's technically what they are, how they're causing hypoxia. And impaired diffusion is due to an abnormality of the alveolar membrane itself or the number of your alveoli themselves, okay? And you can have these in things like acute respiratory distress syndrome. That's the pathophysiology of that. Fibrotic lung disease, for example, in those preemies with chronic lung disease. And then, of course, you can have just low inspired FiO2, like at altitude. And then with the hypercarbic etiology, you can have, we've discussed this already, increased carbon dioxide production with things like fevers, seizures, malignant hyperthermia, decreased CO2 elimination, like we talked about the VQ mismatch, or just a pump failure. You don't have that central respiratory drive due to your muscles not working, your brain not working. So when do we talk about getting a chest X-ray on our, where does that fall in our secondary? Yeah, so these are things that, you know, sometimes you'll get to in a PALS case when you're you've wrapped up the case and you think, this is probably pneumonia, we're starting all these treatments, we can order a chest X-ray now and a blood gas while we wait for the patient to be admitted to the ICU. Like that's how, we rarely even get chest X-rays in PAL cases. These are very much a late thing to get, but remember that would be part of your secondary assessment, imaging, labs. So we have just now covered our lung. So we've done this and this. I want to go over this and this really fast, even though we've talked about this, and we have like 10 minutes, less than 10 minutes. So I'm going to go really fast now. 3-year-old respiratory distress, PAT, they're lethargic, they're breathing fast, they're grunting, they're pale. Here are their vital signs. Initial assessment. Distress or failure? Distress or failure, or both? Failure. And why failure? Pale, grunting. Okay. We're losing kind of all of our signs of the triangle right now, right? So signs of maybe the hypercarbia. Boom. Okay, good. So we have failure, and we need to interact immediately. Give them oxygen, set up their monitors. Primary assessment. They're grunting. They're breathing fast. They have retractions everywhere. They have crackles on the right side. They're hypoxic. It comes up when you give them a little oxygen, but not so much, only to 88% on the non-rebreather. They're tachycardic. They're pale. And they're only responding when someone talks to them. So they're looking a little lethargic, and they're febrile. At this point, identify, what do we think is most likely going on, and what do we want to do? Right, so again, like you haven't gotten into your secondary assessment. Of course, I would say pneumonia too for PALS, compartment, lower, lung tissue disease because of the crackles before we get into our diagnosis of the secondary. So lung tissue disease, you want them to be comfortable, of course. You want to see how they respond to oxygen. Now we're getting into their sample. So they've had, they've been sick for a few days. They had diagnosed with influenza. They are now, that you've started the oxygen, their saturations have now come up to 100% on the non-rebreather. They're still tachypnic, tachycardic, high blood pressure. They have retractions with grunting. The crackles are still on the right. Now they have some strong pulses, good cap refill, but they're still lethargic, less responsive. And now they're rousing only to painful stimuli. So before it was to verbal stimuli, now it's only to painful. So at this point, how do we identify this patient? And how do we want to intervene? Do they get better or worse, and we're worried about them or not? Yeah. Mm-hmm.
We have to lower the temperature,
Mm-hmm. Yep.
have the metabolism of
Yep.
child.
Great.
I
Yeah.
would also maybe start the antibiotics.
Great. So yeah.
Something like life-threatening, but
Exactly. All things that I would do. And again, the challenge for all of us right now is doing that identify piece. So this is lower, this is probably, parenchymal lung disease. This is most likely pneumonia. It could be like pulmonary edema. There could be a pleural effusion. With the fever and the diagnosis of influenza, I would discuss, we need to get an IV in the patient. Got to get some fluid started in the patient, discuss ordering antibiotics, some ancillary studies we can get, getting a chest x-ray, we can get a VBG, you know, and we can discuss, you know, exploring our differential diagnosis with a chest x-ray while we call the ICU because we're worried about them. We're preparing for, because he's still working so hard to breathe and we're worried about his mental status, we're probably gonna need some invasive or non-invasive respiratory support with this patient, right? So things you can do while you're someone over there, you're calling the airway person and they're setting up intubation would be the CPAP, okay? The CPAP is your friend in this situation, okay? And that's something you could start in the ED, the ICU would do that, you will do that too, okay? So every time, what you guys have been so excellent because you're like, we need to call the ICU. Now go back to think about what am I going to say to the ICU? They're going to want to know what I've identified and how I'm intervening while they finish wrapping up their 5 million codes before they come down. So you want to be 2 steps ahead of them and say, I think this is lung tissue disease. My working diagnosis is pneumonia. I am going to start the patient on CPAP. I'm getting an IV, I'm going to start some fluids, and I'm ordering antibiotics. My differential includes, you know, edema, a pulmonary, pulmonary pleural effusion. I'm going to look for complicated signs of complicated pneumonia, okay, with the chest X-ray. So, yeah. The what? Ultrasound. Yeah, love. Oh, you guys, Italy, you're experts in ultrasound. And absolutely, and we were talking about this last night actually at dinner, how we would love to figure out creative ways to incorporate ultrasound into the PALS cases to assess for like fluid and for, I love it. Yes, ultrasound would absolutely be a thing to do. You can use it in real life, continue to use it in real life. I look to the Italian literature to help me with my ultrasound. So definitely, yep. So sorry, we are 2 minutes out and we made it almost through the whole algorithm, but we were down here with our lung tissue disease, pneumonia, pneumonitis. It can be infectious chemical or aspiration. Albuterol, of course, is on here. You know, if they're wheezing, you could try albuterol. Really, the treatment is the antibiotics, okay? And the non-invasive positive pressure ventilation to really hold them over to avoid intubation, which would be like CPAP. You can, of course, have pulmonary edema also in this category, ARDS, CPAP, any sort of PEEP, non-invasive positive pressure innervation, ventilatory support, vasoactive support if you start to get into the categories, you know, of shock, which you talked about yesterday with Mark, okay? So we're down here to the bottom of the algorithm. I probably should be starting this talk with the bottom of the algorithm because it's what we think about the least. But really, your disordered control of breathing, your increased ICP, your poisoning or your overdoses, and your neuromuscular diseases, okay? Signs of, has anyone seen a patient with intracranial pressure, increased intracranial pressure, okay? And what are some classic signs that you've seen with those patients? Yeah, Cushing's triad, which is bradycardia, hypertension, and kind of like irregular breathing. Yep. And what's the first thing you want to do if you see that? You've identified it, now what do you do immediately? Okay. Great. Positioning the head of the bed at 30 degrees, lightly hyperventilating the patient and calling for help. Stat. All right. Are there medications that we could be ordering at the same time? Mannitol or hypertonic saline. Okay, so we all know it. This is one of those things that's easy to say and harder to actually recognize in person. And like one of those things that as soon as you say this to someone, it gets every single human in the hospital's like attention. Okay, so it's like we say it really flippantly, but this is a big deal. And if you can recognize this and do those things, you will save lives. Okay, so excellent. Those will be some PALS cases as well. Mm-hmm. And then, of course, and you don't want them to code in the CT scanner, so that will come later because you really want to do a nice pupil exam, do everything you're doing to, initially. Yes, absolutely. Yeah.
I want to hyperventilate this patient.
Mm-hmm.
I have a back mask.
Mm-hmm.
Because 100% oxygen.
Yeah.
If it's not breathing, I can't hyperventilate it because he has spontaneous breathing.
So he's not going to be breathing so spontaneously if he's really herniating. Yeah, that's where the irregular breathing's coming in. It's sort of like your post-seizure patients. he's totally not, he's not with it if he's herniating. like Cushing's triad, they're actually herniating. So you absolutely will bag. You absolutely will be able to bag this patient. If he's fighting you, you're probably like not herniating. Yeah. So the last case that you're going to read on the notes is a patient with a seizure. Okay, like very much the patient you're talking about right now. Okay, he had a seizure. He got some benzos. He's breathing irregularly. You're going to bag him. Okay, and that's this case. Okay, so review that case for PALS. You are going to really watch him very closely and be thinking about using that nasopharyngeal airway in a patient like this that we talked about initially. Okay. And if he continues to become more responsive on your assessments, that's when you can hold off. If not, you want to discuss things like if he's getting worse, you're going to need to be intubating this patient, okay? Because he's just not breathing on his own. So I want you guys to review that case on your own with PALS. And then there's several other slides in here that just get in deeper into the physiology of the respiratory system. But I really wanted to cover the main cases and the main compartments for PALS today, give you a nice overview. And I'm sorry, that I'm cutting it a little short, but you have all these slides, and you've really now been exposed to everything you're going to see in Latina for the respiratory cases, okay? Questions? Very good question. Yes, so very good question. It totally depends on the provider. These are patients where I realize that I have a low threshold to be in a situation where I'm gonna be able to get more help. So if that's in a big emergency department in the back room, with this patient I would say I want to move them to resuscitation bay. And that way I get people's attention, and I get people helping me, I'm making people set up for an intubation, I'm getting pharmacy, I'm talking about my intubation medications, I have someone very, very focused on just breathing for the patient, and if all goes well in the world, they start to wake up, which this patient does. And then I'm like, whatever, bye everyone, and everyone loves being called off of a resuscitation. They're like, oh, okay, great, I'll go get a cup of coffee. However, he's very concerning for me. His mental status, he's altered, he just had a seizure, is he gonna have another seizure, okay? So you're really worried. The simple febrile seizure patient, so, and I just want to end with this because it gives me a lot of respect for like ambulance crews and parents, because you think about it, you have a 3-year-old who has a simple febrile seizure, right? And they stop breathing, and it's terrifying. And the seizure breaks on its own, and they're post-ictal and breathing irregularly afterwards. By the time they get to us in the emergency department, they're like looking awake, and we're making sure they're at their neurologic baseline. We don't do anything for these patients, and we send them home. But think about it, if you saw this in the emergency department, you'd be like calling for help. So I'm always very empathetic with the family, and I explain like, while we may be discharging your son, I understand that this was really scary, but these are the reasons I'm okay now. So I have a tendency to be conservative, and if they're really not waking up, and I trial them off breathing, and they're really not having nice spontaneous breathing efforts, like let's get you to the bay, and let's talk about, possible intubation. Yeah, they could still be having seizures, and you get into all of that with the secondary assessment. So like you get into, do they have epilepsy? Do they get into some crazy medications? Then you're probably going to be intubating. If they're like really waking up and they had the first time febrile seizure, maybe you're gonna be a little more patient, okay? Yeah, but low threshold to call for help in these patients, yeah. Yes?
In which case you suggest us to use the lavender mask?
Oh, I love the LMA. The LMA?
Yes.
I mean, now it's considered an invasive airway. So absolutely. So use it. If you have it, you know how to use it in any patient that you would otherwise be intubating. It's a great way to hold you over.
But for example, the problem is Cooper.
No, because no. You're not going to be intubating the Cooper. I mean, if you're going to be intubating the Cooper, you're not going to want to make them upset, right? You're going to have to knock them out. But the LMA, you have to knock them out anyways. I mean, literally consider it, it's an invasive airway. So you're treating an LMA like an intubation, they're just easier to get in, okay? Right. Has anyone ever seen an LMA used? Okay, and when has it been used?
When the patient that you understand that the patient has to ventilate itself out.
And are they conscious or unconscious? Right, so this is not your Cooper who's kind of awake, and this is a patient you would be intubating, but either you can't intubate, or but they're really excellent. okay? And you can do continuous CPR with, you know, continuous respirations with the LMA, and yeah.
My question is,
Mhm.
why I have to put a gel when I can put a laryngeal mask? I have an unconscious patient.
Mhm.
If he's unconscious, I can use a nasopharyngeal. If he's conscious,
Or, yeah,
if I need some help.
right,
If he's unconscious,
right.
I can use Gedel to
Mm.
ensure airways.
That's an oropharyngeal, or that's an LMA?
The,
Yeah, you can use an oropharyngeal. Mhm.
it's better to use an LM.
So an LMA, I would put on an, I would be giving them anesthetic medications through an IV if I have an LMA in, okay? The oral pharyngeal tube, they're completely like, the oral pharyngeal tube is a holdover while you're figuring out what's going on. So that it kind of is it's an intermediate intervention, okay? So where you have an unconscious patient, you have no idea why, you know that they're unconscious and you need to open this up and you're in a setting where you don't have a lot of help. It's a quick thing to put in so you can bag. You go to the bay and you're like, wow, this patient needs to go to the CT scanner and we need to get all sorts of labs to see what he ingested and what's going on. And you're like working through all of your differential. Now we need to get an IV in him and we need to intubate or put an LMA in. Okay, so now they have rapid, RSI meds going, they have an LMA, they have someone breathing through the LMA or, for them. So quick solution, less quick solution. All right, we're done. Coffee break. Sorry to keep you over. Really good questions. Thank you for the questions. Excellent questions. You guys are incredible, okay? Yeah.
Okay, good. Sorry? Is it going? Okay. Okay, great. Okay, ragazzi, I guess this session is streaming or something, so I have to use the microphone for this, which is hard for me because I'm usually explaining things with my hands a little bit. But so, okay, welcome. This, I guess, is the last session for your rotations. So I've been going through, just to start, just having a quick little introduction. Each person, your name, where you are in school, and then where you're really from. Where are you from? Because sometimes those are different, right? So maybe can you just say?
My name is Giorno. I'm from La Sapienza in Rome.
Okay, and you're also from Rome.
Rome, yes.
Both. Okay,
Yes.
you're Roman and you go to school at Sapienza. Okay, how about you?
Sapienza, Rome, and I'm from Battipaglia, Salerno. Here in Naples.
Oh, nice. Okay, close by.
My name is Chiara. I'm from Rome and I study in Rome, La Sapienza.
Okay, good. I know you, but you know, are you also? I've never known. Are you really from Trieste? Yeah. Okay, that's cool. It's nice to be where you're from. Yeah.
I'm Francesca. I'm from Trieste and I work in Trieste. It's fine.
And you grew up in Trieste also? Good. Okay.
I'm Lisa. I'm from Reggio Emilia and I study in Parma.
Okay. Okay. Close by. It's nice.
Hi, I'm Elena. I'm from Milan and I work in Parma.
Okay.
I'm Marco, I'm from Calabria in the south of Italy and I work in Milan.
Oh wow. So you're going a long way. Yeah. It's a nice kind of an adventure. Yeah. In a way. Yeah. Okay. Nice. And I know Antonio, and he's in Napoli, but also it's where you're from, also Napoli. See. Yeah.
I'm Santina. I job in Biancavilla Hospital in the area of Catania.
Okay. Okay. Nice.
I am Elisabetta and I live in Catania and I study.
Live and study in Catania. Nice.
I'm Laura and I'm from Catania and I study in Catania.
Okay, good. Do you know each other a long time? No.
3 years.
Oh, okay. I'm always trying to find, do two people know each other since they were bambini? That would be kind of cool, but maybe somebody knows a long time. How about you?
I'm Laura and I'm from Catania and study with
Okay, nice. And just friends now, yeah.
I'm Giovanni, I'm from Napoli, and I'm studying Perugia.
Perugia, oh, super.
I'm Michele, I'm from Puglia, Bari, and I study in Siena.
Okay, Siena, nice. Palio, I have to see it someday. Someday I will see it. We were. I know, that's what I understand. We were talking that the Siena only has a population of maybe 50,000. Not so many people, but a lot of people know about this, the little city. Yeah. Okay.
Hi, Vanita. I study in Siena and I'm from Bari.
Oh, okay, good.
I'm Rosa. I'm from Salerno and I study in Salerno.
Oh, nice.
Hi, I'm Luigi, I'm from Naples, Napoli, and I study in Salerno, Naples.
Okay.
Giuseppe, I study in Catania and from Agrigento.
Oh, okay. Agrigento, is that what you said? Oh, wow. Okay, that's cool too. I would like to go there to see, of course, the Greek. Yeah, nice.
Hi, I'm Beatrice. I'm from Rome and I study in
Oh, Abruzzo. Oh, great. I always like to know because I've had many trips to Italy. I think maybe more than 10. I went to university in Rome when I was in college, but it was an American-speaking university. So sometimes I have known some Italian, but Spanish I know a lot more. But I've had a chance to travel literally from Bressanone to Brindisi, and I have gone from, I've been to Trieste on this side. I've been to Catania down here. I've been to some small places like Ponza, which is really nice. A little place in Tuscany called Follonica, which is, yeah. So I have a friend from Follonica. So there's many, and I've been to Milano and Firenze and these big cities, but there's still a few that are, many that I have to see. Bologna, I've never seen still. I know. And Bari, right? The Adriatico, I don't know any part of this part of Italy. So I've been to Larga di Garda, Lago di Garda. Yeah, that's very beautiful. Anyway, so I love Italy. I love hanging out with Italians. Okay, and I'm from a town of only 700 people. 700, yeah. So we have no stoplight. We just have a stop sign, a post office, one restaurant, one bar, and a grocery, basically. But it's a special town because we have a lake there that has very pure water, more pure than the drinking water of the capital city. So in my town, if you can just drink out of the lake and you'll never get sick.
What's the name of the
It's called Battle Lake, Minnesota. So it's in the north of the United States, right in the center. Very cold. But now I live near San Francisco. So anyway, okay, so we'll talk about shock today. I think the other sessions, you know, there's many things to review of the algorithm for respiratory and the algorithm for, you know, arrhythmia and defibrillation and these things. I think the shock talk is a little bit different. The algorithm is not so complex. You know, usually it's trying to decide what kind of shock and then giving fluid and assessing the baby. So for this talk, it's really more like a medical school talk. I really think it's nice to talk about physiology, really to try to have a deep understanding of shock, deeper maybe than you have now. And it will help you in the Giocchi because you'll just know more about shock and you'll be able to be more comfortable with treating shock, if that makes sense. So it's a small group, we can have some conversation. I just talk for a whole hour and sometimes do some stuff on the blackboard, but we can have conversation too. You can take notes. I mean, some people like to take notes, that's fine. But I also created a review of 250 words. Did you hear about it? I don't know. A review of each hypovolemic, obstructive, the different types of shock. A quick review, and then with the magic of ChatGPT, change to Italian. And it's pretty good. The Italian is pretty amazing. My friend looks at it, he's like, yeah, I can understand it very well. And then I put it on my Dropbox and I create a QR code. So when we're done, if you like, you can just take the QR code and it'll review this conversation. What we will do though is look at different definitions of shock, understand the types, review the algorithm for general shock, and then some details about septic shock. But again, mostly it's going to be a lot of physiology, which is fun. So really, shock is the syndrome where the tissue wants more oxygen than it gets, or more nutrients than it gets. So the tissue is needing more than the delivery. So in other words, the metabolic demand, the demand of the tissues or the cell is greater than the delivery of oxygen to the cell. So it can be caused by too much demand, but usually it's caused by not enough delivery. Does that make sense? And you have all kinds of problems if you have shock, because no cell likes to be in shock, and some cells die very quickly in shock. The brain, you only have a few minutes. If the brain is really in shock, like no blood flow, you die very quickly. Other cells, like I like to say the skin or the leg, the extremities, they don't need as much blood flow. And that's why in shock, we sometimes see the movement of blood away from the extremities back to the central. Because the organ that needs the blood flow, this one, if this one is dead, then you're dead. The other organ that needs the blood flow is the heart. If this one is dead, you're probably dead. Maybe we can put you on ECMO or something, extreme. But the heart and the brain really have to have their blood flow. So those are the biggest focus when we have shock. Remember, hypotension does not equal shock. We can use hypotension to categorize shock. If we have shock, then we can say, is there hypotension, yes or no? So it's compensated shock, which is normal blood pressure, and it's decompensated or uncompensated shock, which means low blood pressure. But you can never, never, never say, oh, the blood pressure is normal, this is not shock. That will be a problem if you do that. So this is sort of how we think about it with physiology. This is VO2, this is the demand or the consumption of oxygen, and DO2 is delivery of oxygen. So when the consumption is bigger than the delivery, you have shock. And all of the things that go along with that, remember, when the cell does metabolism, we are aerobic creatures. We live in oxygen. And our cell is very happy when it has enough oxygen. So remember, like when you make ATP from medical school, and if you have oxygen, I think you can make 38 moles or something of ATP, or some high amount. And if you have no oxygen, you make like 2. Do you guys remember that? The anaerobic metabolism versus aerobic. I just say that because when you're in shock, everything is breaking. The machine is breaking. So the cell is not happy. ATP production is down. The cell is generating metabolism without oxygen, and it's anaerobic. So we have the production of hydrogen ions. Hydrogen ion goes up, pH goes down. Oh, that's no good. Because remember, every system in our body, the enzymes are happy with 7.4 pH, plus or minus just a little bit. If you, this is a lot of biochemistry, and I'm not a biochemist, but remember how proteins work and enzymes work. If you take the same enzyme and move it to a pH of 7.3, the activity goes way down. And you move to 7.2, the activity goes way down. So all of the systems of the body are unhappy with shock and acidosis. So that's why it's really a disease for people that are hyper, people that want things to change fast. I want you to be hyper alert and hyperactive when you think the patient has shock. Because it's not something, every minute you're in shock is a bad minute for your body. You want to get someone out of shock as soon as possible. Okay, this is basically the whole world of shock in one slide. But just to give us the idea of how we classify. And really, okay, there's a weird one down here called dissociative. We won't talk about that too much today. But the big ones, hypovolemic, cardiogenic, obstructive, and then we have some distributive too. But this is all about pumps and plumbing, just like in a house with pumps and pipes and water and pumps, right? You have a pump, it's called the heart. You have pipes, that's called the blood vessels. And you have water, which is called your blood. That's your volume. So if you have hypovolemia, you don't have enough fluid, right? The volume is down. So you can have a pump that's working great. Your pump is beating strong, but there's not enough fluid in the pump. So the output is down. That's hypovolemic. That's all it is. You can have a system where there's plenty of fluid, but the pump is just going like this. That's pump failure. That's cardiogenic. You can have distributive shock or obstructive shock. Obstruction means, again, there's an obstruction. The pump may be beating hard, but the blood can't get out. Maybe you have aortic stenosis, right? And you have, the pump is banging away, and the aorta is tiny. So that's shock. Or you have a tamponade or tension pneumothorax, and it's obstruction to the inflow of blood. Because remember, the blood comes from your body, your SVC, your IVC, vena cava, and it returns to the right atrium with low pressure. Remember, the pressure in the right atrium is maybe, like 10 or something. the central venous pressure is 3 or 4 or 5 centimeters of water, it's low. So if you have a pneumothorax and the pressure in your chest is 30, this blood cannot return to the heart. So that's an obstruction. This is basically all there is to know about these. And then distributive is a unique kind where there's distribution of blood to the wrong place. So we think about anaphylaxis, where you have vasodilation and all of your blood goes out of your central circulation to your body. Or we think about neurogenic shock, which is like spinal shock. If you have an injury to your spinal cord, the tone of your blood vessels is lost and you have vasodilation and you can be in shock. You can have the same amount of fluid in your body, the pump is working great, but your fluid is gone to your feet. Your capillary refill may be 1/2 second, right? So these are distributive shock. And then this last strange one, dissociative, you think about this as like a shock with the cell. Everything else is perfect, the pump is working, there's fluid, you're giving oxygen to the tissue, and then the cell can't receive the oxygen for whatever reason. And so I just have to use some of my hands. The best idea for this is carbon monoxide. Here's hemoglobin, here's oxygen. Normally the hemoglobin carries it out to the tissue, the oxygen leaves. You remember carbon monoxide just grabs hemoglobin like this. It comes to the heart, it goes to the lungs, no oxygen. It goes to the body, comes back, it's blocked. So you're in shock because the cell is saying, I want some oxygen, and all the hemoglobin that's coming has no oxygen to give. There's other things, cyanide and stuff like that, but. So this is, any questions about this? This is really all of it to try to categorize it. I don't know, hemorrhage is worth noting. Of course, it's low volume, but especially loss of blood. So when you recognize you have hemorrhagic shock, you can't just give saline. You do have to give blood, because remember, saline carries no oxygen. Cardiogenic, we usually think about cardiomyopathy. And I think for the games, a lot of times we have a scenario of a baby that has, like a viral cardiomyopathy. And so the heart muscle is squeezing poorly. But you can also have other things that make the pump not work. That could be toxins. We've had patients with intentional overdose or accidental overdose, and the pump is not squeezing. After cardiac arrest, very commonly, if it's prolonged, you have what's called post-arrest cardiomyopathy. The heart muscle is not happy for probably 6 hours, maybe, and then it gets better over 12 or 24. So the heart muscle just had a long period of time during CPR, and even though the baby is resuscitated, the heart's not squeezing well. Has anyone ever seen, the last group have seen a baby with SVT? Has anyone ever seen an SVT baby? Stefania for sure, Antonio for sure. Have you guys seen an SVT baby? With the heart rate of like 240 or something? Here's how that goes sometimes. The mom says, the baby seems okay, but for 2 days, not doing so well. 2 days ago, just not eating so well and starting to breathe fast. And then today, kind of sleepy. But when you look at the baby, his refill is okay. And when you check his pulse, you learn something. You put on his pulse oximeter, and his heart rate is 240. Wow, it's SVT. But you guys remember this, it's stable. The blood pressure is 90/50. And so you can give adenosine, SVT is resolved, and you think, I saved the baby. Oh, you did, good, congratulations. But now, actually, he has a cardiomyopathy sometimes, because for 2 days, or maybe 3 days, this heart is beating 240 times a minute. And it's just like if you tell me to do push-ups for an hour. I will not be able to pick up my own hand. So the heart muscle is tired, and so you can have a cardiomyopathy from arrhythmias. So 2 people last time had a baby come with the exact same story in the last group. 2 days, it's a classic, SVT. It can also be VT. 16-year-old boy says, something's funny in my chest, and I try to play soccer and I'm just too tired. And you put him on the monitor, boop, 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 boop. It's wide, it's fast, it's 120 or something. He's 16, strong boy. It's like, oh my God, you have VT. But okay, it's stable VT. It's really crazy, right? So you can fix that. The cardiologist comes, maybe you give amiodarone, I don't know. And then he still is not back to normal. And if you do his ultrasound, his heart is not beating strong. So these patients have cardiogenic shock. So it's a lot of talking, to tell you about how arrhythmias can result in cardiogenic shock. But anything that makes the heart muscle not happy, it can also be congenital problems. Last thing for this slide, this word sepsis appears everywhere. This is why septic shock is hard. Septic shock, you're very often low on volume. Why? 2 reasons. 1, you're sick, you're not drinking. Maybe you're septic with a diarrhea, you're losing fluid. Number 2, the heart, because of the inflammation, is also not beating too strong. Oh, so now you have 2 types of shock, hypovolemic and cardiogenic. And remember, sometimes with septic shock, we get vasodilated and we have moved our blood to our periphery. So that's a relative hypovolemia. So, so septic shock is the hardest, for sure. The easiest is this beautiful one right here, just pure hypovolemia. And sometime in your pediatric career, you'll get a chance to see pure hypovolemic shock. You'll always remember it. It's a pleasure to see a patient with it. This is the history. Baby is 3 years old. He gets a virus of the gastrointestinal system. For 3 days, everything he eats pukes. And he's pooping out diarrhea like crazy. 50 per kilo. And he just comes in like a doll. He's just floppy. You put his IV, he doesn't even respond. The mom thinks he's dead. Everyone thinks he's dead. But you take a quick listen to his heart, and his heart rate's fast and it's beating strong, and his pulse is weak because he's in shock, but no big liver, he's just dry. And you give 20 per kilo of isotonic crystalloid, and just like a flower that gets water, he just comes back to life. It's so magic. And you can do it in an hour. And you give 20 per kilo, and unresponsive, remember AVPU? You guys remember for a second? The reverse is really cool. UPVA. So he's unresponsive. You give a bolus, and now he starts to, he's fussing a little bit, and you poke for another IV, he cries. That's an improvement. You give 20 per kilo more, and now he's responding, Johnny, he starts opening his eyes. You're almost there, give 20 per kilo more. Sometimes it's even more, 40 per kilo, 80 per kilo, 160. The point is, it's the most beautiful, pure resuscitation you've ever seen. I personally like to be pushing the fluid myself because it's so much fun to watch when you can see it. And you feel for a moment in your life like, okay, it's almost like being a god. You're like, I'm giving life back to you. And the mom is excited, and you're excited, and the baby's happy. He doesn't have cancer. He doesn't have sepsis. So if you ever see real, just pure hypovolemic shock, you have to be excited about it. You have to. And you'll always remember it. And it teaches you the best management of shock, which is frequent reassessment. I mean, that's what pediatricians have to do. We have to frequently reassess the patient. So much more than adult medicine, because the baby gets sick quickly, and they get better quickly, and they can't tell us the problem. When the old man is starting to have sepsis, I don't feel good, this and that, and he slowly gets worse, and then he slowly gets better. The baby is good, boom, bad. But then they also come back. So This is, I've already told you, it's just said in a different way. Shock has decreased cardiac output here, whether the pump is dry or the pump is not pumping hard. Distributive shock is a little different. Usually the cardiac output is increased, ironically. So you can have shock even though the cardiac output is elevated because the blood is going to the wrong place. And these things are interesting. This is systemic vascular resistance. That is the tone of your vascular system, right? Is it high or low? So we say when you are vasodilated, you're red, your refill is 1/2 second, that you have a low SVR. And so that would be like a distributive shock, or that can also be like a septic shock. And we say when you're hypovolemic, you have an increased SVR, your blood vessels are squeezing down, you have increased tone. And that's elevated SVR. So, just a little secret, but there's nothing I can do about it. It's not exactly true. If you have a long capillary refill, 4 seconds, you actually may not have an elevated SVR. I'll just tell you that. It's like a little thing you can learn. We used to put in pulmonary artery catheters and measure this exactly. We don't do that now. It's hard to do. It's somewhat dangerous in babies. But the case would be, if I go outside and it's cold, and my capillary refill is 4 seconds, I'm cold. It doesn't mean I have an elevated SVR, really, okay? Or if I'm nervous, sometimes you're nervous and you're like, oh my God, I'm cold, my fingers are cold. You're not in shock. You're just nervous. So you don't have an elevated SVR. I'm sorry, it's true. But it does make me think about all the ways that we get fooled by shock and we miss the diagnosis. So the classic would be 1-year-old baby, he weighs 10 kilograms, he's been sick for a little bit, and he comes to emergency department at 2 in the morning, and his heart rate is 150, and you don't realize that he's in shock. Why is that? Because we're pediatricians. Babies have a normal heart rate of 150. So all night working in the emergency department, you're hearing about babies with heart rate of 150. So if I say to you, patient's heart rate is 150, you're like, okay. If you take care of adult, and I say to you, Mr. Smith, his heart rate is 150. You'd be like, what? It's way too high. But we're pediatricians, okay, heart rate 150. But for a 1-year-old, that's probably too high. Or the nurse says, oh yeah, he's upset. His mom had to leave. He's crying. Okay, that's why. We poked him. So you find a way in your mind to say heart rate 150, that's okay. Oh, and his refill is 3 seconds. Well, it's a cold night. We're living in Bressanone. It's very cold. And so maybe that's why his refill is long. Okay. And he's really sleepy. Oh, well, it's 2 in the morning. It's the ER. Of course he's sleepy. You can find reasons to ignore all of the signs. And that happens. Everyone here you will have a patient that you don't recognize shock. I'll just say it right now. It's going to happen to you. It's happened to me. Now, if someone comes in and they have a cut in their leg and they bleed, okay, you're not going to miss that shock. But you will miss the shock of this baby I'm describing. You can also miss septic shock. The baby's a little tachycardic, but he has a good refill. He's still alert. He's in early shock. So the nice thing you can do is turn the table and just try to convince yourself, why does this baby not have shock? So start with the assumption, I think this patient is in shock. Don't explain away the reasons. 2 in the morning, oh, you're sleepy? Well, let me come see you. Let me try to wake you up. If you're tired, okay, I can wake you up. Or are you really like unresponsive, right? So turn the table. You tell me the heart rate is 150, 180, something, because the baby has a fever. The nurse says, don't worry, the fever is 40. Let's give Tylenol. Okay, that's fine. Probably right. But you have to come back. Now, the Tylenol is working. The fever is 37.5, and the heart rate is still 170. Oh, the patient is upset. I just poked for labs. Okay, I'll come back. You see the idea? Okay, I'll come back. Okay, I'll come back. You need to reassess the patient many times. And the reassessment is quick. You're busy, the emergency department's busy, but it's just a quick, oh, I just saw you 10 minutes ago. They poked you, but now you're not crying, we're not poking you, and your heart rate is still 170. I'm not liking it, right? So come back, do frequent reassessment. You really have to do that. I already went through all of this stuff. Pump is dry, pump is weak, pump is blocked, or this is bad. Septic, the pump is dry, weak, and the pipes are leaking. So it's distributive, it's cardiogenic shock, and it's hypovolemic shock. Sepsis is a bad one. So the important thing, and I've already sort of talked about this, is that you will be required to begin treating shock usually before you know exactly what kind of shock you're treating. Like I already said, many people won't even see it's shock, but when you recognize it is shock, you have to start the treatment. And of course, you're going to try to figure out the problem, and that always comes up in PALS. Let's have a CBC, let's have electrolytes, let's have a blood sugar, a glucose, right? That's fine, you have to do that. But remember, every minute that you're in shock, the body is not happy, the cells are not happy. So you have to start a quick treatment, and it's a disease for, I think I said, for hyper people. You have to be hyper. You have to be hyper alert and hyperactive. Reassess, treatment, reassess, treatment, you know. It's not a one to be like, okay, I'll come back in 4 hours. No, I'll come back in 15 minutes. And I will look at your urine output every hour, right on the top of the hour. I mean, even in the busy ICU at Stanford, one of the few things that I personally am looking at with my own eyes is the urine output. And people are like, wow, there's a million things you can look at. CAT scan, x-ray, everything, labs. Okay, cool. But wow, the urine output every hour tells me so much if you look and see how that goes. And you guys remember, for monitoring people in shock, we'll talk about it, but urine output is one way that we can do it. So here's a general approach. Keep in mind that you will have to treat before you know the answer. But initially, you're going to look for these signs, and we've already talked about these. Pale, mottled, prolonged capillary refill. This is like a cold shock. But it could be short, quick capillary refill if it's warm shock, right? Distributive shock. Altered mental status, tachycardia. They put bradycardia. That's a bad one. If you're in shock and you have bradycardia, get ready. It's almost cardiac arrest. It's coming. So anyway, diminished peripheral pulses. This is part of the assessment that's so nice to do. And when you have the little toddler, you can just literally have your hand on the femoral pulse and the foot pulse and the refill. And you can just be there and watch it. It's worth your time. And they give the first bolus, maybe you push. And notice when I say give the bolus, every time I make this motion. Because a bolus is given with pushing. A bolus is not given with the pump. How do you know that? Imagine you have a girl who's 16 and she's 50 kilos and she's in an accident and has hemorrhagic shock, you think? And you say, I want the first bolus, 20 per kilo, that's 1 liter, and someone puts on a pump. That will come for in 1 hour, right? Because the fastest you can do is 999. That's 999 milliliters in 1 hour. Well, she needs to receive it in 5 minutes or maybe 10 minutes, not 60 minutes. So anytime I come to a patient, I'm hyper a little bit, I'm an ICU doctor, and someone says, oh, we think this patient's in shock, we're giving some fluid. I'm like, super. Basically, where's the syringe? Oh, no, we have fluid going. And then you look at the pump and you're like, okay, well, that's not really a bolus. Unless maybe it's a baby and it's going 999. But the nurses never do that because they don't want the IV to blow up. See what I'm saying? If I have a little baby and I said sensation of shock initially is really best managed very personally. You yourself are going to be very involved. With frequent or almost continuous reassessment, you can just leave your fingers on the pulse and you will feel diminished and absent. Like sometimes you literally cannot feel the pulse here, or barely. That's because the body is relocating all of the circulation to the center. Remember, the heart and the brain have to have their blood, for sure. So the body, it's a compensation. There's a vasoconstriction, systemic vascular resistance is up, and there's so much vasoconstriction that the pulse in the foot and here is maybe like, I can't even feel it. And it's diminished here, and the baby is unresponsive. And then here comes the bolus, and I already mentioned, unresponsive rises up to pain. The brain is starting to wake back up. You're resolving the shock. And all of a sudden, you can feel this a little bit better. And you give another bolus, and now this is strong. you. Yeah. So they took these children and looked, Joe Carcio, this is a famous paper, but it's nice to know the old literature. And they had 3 groups. Babies who got 20 in 1 hour. That's not very fast, remember? I said you should have 20 in 10 minutes. But back then, maybe they didn't resuscitate as fast as we do. 20 to 40 or greater than 40. And what they found was, if you got 40 per kilo or more, you didn't die. And if you only got 20 or 40 per kilo, you actually had a 50% chance of death. These were kids with bad shock. So everybody who's my age who does critical care knows this paper. Now things change, of course, with time. And Stefania, for example, does the international global health. And there's a very important paper by Maitland, M-A-I-T-L-A-N-D, where she looked at shock in the developing world and found, you know what, give less fluid. So I think a lot of global health now, you know more than I do, is giving less fluid. But there's a difference, as she very well knows, and you know obviously too. We're lucky, we have everything. We have ventilators, we have endotracheal tubes. If you're in some parts of the world that's developing and you give too much fluid, you actually may kill the patient because of pulmonary edema. They don't have a ventilator. So they're like, okay, let's give a little fluid. Here we can be aggressive. Give me fluid, more. And then, oh, sorry, too much. Maybe I'll give you some diuretic. Maybe I'll put a breathing tube in you. Maybe I put you on BiPAP. See, we have more options. So the Maitland paper is very relevant, but for that environment. I will also say in critical care in general, in the last 5 or 10 years, we're more interested in being careful with fluid, certainly after the first 24 hours. This isn't for your pals, but just to let you know. We have better outcomes in the ICU if we start controlling our excess fluid earlier. When I was a fellow in 97, 98, 99 in critical care, it was like wham, 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 huge amounts of fluid. People would get super puffy. We'd give them a ventilator. They'd be on the ventilator. They would live, but they would have several days on the ventilator. So now we're starting to be a little more like, okay, just cool it. You don't have to give so much fluid. But I don't want the pendulum to swing too far. I don't want it to be, I think we're worried in critical care like, oh, now people don't give enough. If you're in shock, if you think the baby has hypovolemic shock, you need to restore their vascular space. And you need to feel the power to give fluid as you need. 20 per kilo, I think you're getting better. You don't have RALs, your liver's not down, your perfusion is better, 20 more per kilo. I think you're getting better again. Now, so you guys get the idea. So don't be afraid. Understand that fluid can be harmful, but don't be afraid to use it. It's like anything. Fire, it keeps you warm and it can burn you. Doesn't mean we never have a fire to keep warm, right? Just be careful. Morphine, it treats your pain. It can also make you stop breathing. So fluid, it's good for you. It can also be bad. So these were the goals. I mentioned these. We've already sort of gone through these. Sometimes we talk about SVO2. We're running out of time, but I just wanted to be able to have a little bit on the blackboard. So this is more about septic shock. It's the same concept, okay? But the notion is give oxygen initially. I'm going to talk about that in a second. Give this resuscitation. And in the first 15 minutes, you are going to determine yes or no. Is this shock responding to fluid? This is another reason why you can't use the pump. It's a little bit of a goal that may be hard to achieve. I mean, if you think about it, can I really give you 60 milliliters per kilo in doses of 20, 20, 20? Can I do that over 15 minutes? It's hard, because it is hard to get, it's hard to do it in 5 minutes. But this is the goal. And what happens is, after you've done that, then you make your decision. And I've found that all of the students already know this. We decide, does the patient have a warm shock or a cold shock? And we do that by vasodilation. So if the patient has had fluid and is still in shock and is vasodilated, which drug do we use? If they're warm, norepinephrine. And if they're cold, which by the way is much more common in children, what drug do we use? Epinephrine or adrenaline. That's really the PALS part of it. Adults with sepsis tend to present to come in with vasodilation. Usually kids come in cold, clamped down. So more common for cold shock, cold because they are literally cold, and their refill is long. So then you start epinephrine on those patients. And then after an hour, if you're still not making progress, then, okay, should we give steroids? Do we need to get, a pulmonary artery catheter? Probably not. Echocardiogram, central access, these kind of things. And then beyond 60 minutes, this really goes to critical care. These are in the shock guidelines you can see here, and I have references for you at the end. I've told you everything you need to know for the PALS and for the games, but this is what you need to know for your future and life as being a doctor. So when you follow the guidelines, the patients actually do better. And it's kind of a funny thing about medicine. We know things, but we don't do them. And when you ask a doctor, oh, do you understand the shock guidelines? Yes, I do. 60 per kilo over 15 minutes, reassess, warm or cold, start epi, start norepi. Okay, you're a very smart doctor. Let's come to your ICU and let's see. Here's a patient. How much fluid has he had? Oh, just 20 per kilo. Okay. Why is that? See my point? We know the guidelines, but many of us don't do the guidelines. Some of us, because we're just like, oh, cranky, I don't believe it, I'm smarter than everyone. Sometimes you're busy, whatever it is. But it takes a long time to get what's called guideline adoption. Sometimes there's been a study. How long did it take ICU doctors to adopt the guidelines for ARDS? It's about 17 years. Yeah, 17. There's a study that shows it. And you know why that is? It's about how long it takes for the old guys to retire. Because if you're 40 when the new guidelines come out, and you're like, oh, I'm smarter than that. 17 years later, you're 57, you're like, oh, okay, I'm done, I'll retire. And then the new person comes. But the new person has their problem too. So please, be smart doctors, know the guidelines, and then use the guidelines. That's key. So how do you know the guidelines? They're always changing. But for sepsis, I'll tell you there's a resource that's super. survivingsepsis.org. I myself go to that website when I have a real septic shock patient. Septic shock, if you have a patient who has cancer, his white blood cell count is 1,000, his fever is 41, he has a central catheter. This is the scenario we give you when you first do the games, something very much like this. We don't try to trick you. We start easy, and then it gets harder. Okay, let me see. He's a cancer, fever 41, and positive blood culture and central line. Okay, it's septic shock. Some of those patients respond with just a couple boluses, and they're good. But if someone's really not responding, go to survivingsepsis.org. They have always the latest guidelines. They have the PDF. I will go there a few times a year, click it, make sure, do I still know the latest guidelines? It's nice to be able to find it quickly. So take-home message for sepsis, or for all shock in general, but sepsis specifically, Manny Rivers did this study. It's another old study. But what it shows is, if you can achieve these targets in the first 6 hours, and this is really more critical care than PALS, but okay, you gotta have the patient making pee, their hemoglobin or hematocrit is good, their blood pressure's up. If you can get it done in the first 6 hours, you're more than twice as likely to survive. So it makes my point. Know the guidelines, use the guidelines, be hyper, make frequent reassessments. So in conclusion, shock's not uncommon. Shock can be hard to diagnose. There are different types of shock are different. Shock in children is different than adults. Be aggressive. If you delay your treatment, it's likely to result in death. This last thing, because we started a little late, right? So we have maybe 5 minutes, I think, or something. So, this idea of, remember when VO2, that's the delivery of oxygen. When VO2 is greater than VO2, that's shock, right? Remember that? So, yeah, this will just happen. I think you can probably hear me. So, when VO2 is greater than VO2 is greater than VO2, you have shock. So, how can we control this delivery of oxygen? How do we deliver oxygen to people? That's the whole idea. That's what delivery of oxygen is. It's the cardiac output, right? That's the delivery, times the content of oxygen. This is good too. So how much oxygen is in the blood and how much blood we're delivering. That's all there is. But you have different things you can control here. So what is cardiac output?
Stroke volume times heart rate.
Perfect. That's so simple, right? It just seems simple. There's a pump, a certain volume of blood goes out with each beat, and how many beats are there? That's super simple. So we've got heart rate, and we've got stroke volume. That's cardiac output. And then this one, I don't know, some of you remember, do you remember 1.32 and the hemoglobin? Does anyone know that one? Okay, it's fine. It's 1.32 times the hemoglobin times the saturation, and then you add the dissolved oxygen, which is 0.03 times the PO2. But we can basically almost cross that off because this is a decimal times the PO2. That doesn't count for much. But what can we do over here if someone's in shock? We've got some things we can change here. Two things specifically. The saturation is the most immediate one. If you ever have a patient in shock, if you say, I think the patient is shock, and they're not on supplemental oxygen, you're making a mistake there. So you have to make sure the hemoglobin is full. Even if the saturation is 95, let's have it be 100. And actually, breathing that oxygen, you're getting some more PO2, so they're getting a little more oxygen content too. So the first step, I didn't say too much, but it's get oxygen on the patient to help them resuscitate. But here's what's cool. So these are the factors we can control to try to improve DO2. But this also shows us why it's a hard job to be a pediatrician. And here's why. If right now you had a terrible hemorrhage, let's say, for example, or I may do an experiment on you. We open your artery, and you have 5 liters of blood. You're an adult male, and we put 500 milliliters of blood into a bucket. So you've lost 10% of your circulating blood volume. That's shock. If we go to the animal lab, that creates shock. What would happen to you? What's the first thing that would happen? What would your body do?
Increase my heart rate.
Perfect. Yeah. How much? So you're an athlete. You're a young man who's healthy, and your heart rate right now is 60. Can you double it? Can you go to 120? Yeah, probably. If you just did this for 1 minute, you can go to 120. So he right now can go from 60 to 120. And guess what? He just doubled his cardiac output. He literally doubled his delivery of oxygen. So he can address his shock immediately as an adult. Let's imagine the baby. It's an interesting thing. So if you have a baby a toddler who's 10 kilograms, 1-year-old, and he loses 10% of his blood volume. Remember, the blood volume is about 80 milliliters per kilo. So the toddler doesn't have 5 liters, the toddler has 800 milliliters. So 10% of his blood volume is only 80 milliliters. It looks like a lot, but it's not that much. So the same car accident, if he loses 80 milliliters, he's like, oh, too bad. If the baby loses 80 milliliters, he's in shock, bad shock. So the baby has the same exact model of shock. The baby's heart rate at rest, that patient's heart rate at rest as a 1-year-old might be 120. Can he go to 240? No. Meanwhile, if you're really in shock, could you go to 180? Yeah. 220 minus your age in years is your max heart rate. So you can do it. You're probably 30. So your max heart rate is 190. And if you get the Fitbit or the Apple Watch and go for the hard ride, you can hit it. So he's like a Superman compared to the baby. He can triple his cardiac output with his heart rate alone. Can the baby go up to 360? Obviously not. How about contractility? If you step out in front of a bus, whoa, boom, 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 you feel your heart beating, that's your increased contractility. You can double it or maybe even triple it. The baby can't. So there's so many things that we are lucky as adults. Babies are living like right on the edge, If there's any problem, the baby's in trouble. And so I think this is something that can help you understand, how this works. So for example, the hemoglobin, if you're in hemorrhagic shock, and I didn't really say, But for hypovolemic shock, hemorrhage is a special case. You have to treat shock initially till you know the exact diagnosis. So your first roll is maybe saline, but quickly you get back the labs and it says the hemoglobin is 5 or 6 or whatever it is. You have to give packed red cells. You have to give blood. But again, there's other things you can do while the blood is coming. I can't make your heart rate. I can make your heart rate go up with medicines and stuff, but it's not what we do. But we hope the baby can increase the heart rate. The toddler who's in the car accident and doubles his heart rate from 120 to 240, not possible. So he can only get up maybe to 200. So we have to give him his hemoglobin so he can help up. But remember, all of these are the factors we can control. Give the blood if you need it, make sure they're saturating 100, and make sure that their pump is full. So when the heart beats 100 or 200 times a minute, it's full every time. Okay, sounds like the other people are out. These were some of the references. These are just the classic old, like kind of some old papers on shock. This one's not that old, in 2017, but these are interesting. Like this is the one that talks about following the guideline, the protocol. And this guy's pretty interesting. Manny Rivers is just basically, if you make a protocol and you follow it, people get better. Crazy. And then Joe Castillo, I mentioned that this was the hypovolemia. And then this is that thing I put together for you guys. But it's really not that. It's just 250 words that can give you, that can remind you of basically this lecture. You don't have to put it in frame. It's not anything special. But yeah, it's pretty cool. So anyway, that's all I have. I think we're pretty much on time. But Well, I mean, usually that's the team. In real life, we have someone dedicated to the survey. You mean to go get the simple history and stuff? No. Oh, the ABC. Yeah, and that for us. Yeah, that for us is the team leader. But sometimes the team leader is busy with other things, so the team leader can say, "Can you go assess?"
Because the other day the team leader does not touch the patient.
Yeah.
So we were like, okay, so he's not the guy doing the ABCD.
So for example, during the competition, the leader
In the competition, they always have the team leader not touch it.
So we have to.
But
He,
ok. Milano, Bologna, Bologna, ex Catania, va bene, però devi dire il nome almeno. Ok, Perugia. Perugia, quindi ho parlato ora con Verrotti, mannaggia, lui non sapeva che eravate qua, è vero questo? No, no, non lo so. Quando tornate lunedì è tutta colpa mia, mi dispiace perché l'ho chiamato. Roma, La Sapienza, quindi siete con Fabio, giusto? Con Midulle, ok. Ma lo sa che siete qua? No, 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 non è che è obbligatorio, dico. Perugia, quindi anche tu ti troverai malissimo lunedì. Sara Parma, Parma, ok. Quindi siete, ma quanti siete a Parma ogni anno? Troppi, perché siete tanti qua però. No, siamo felici, non è che vi stavo dicendo. Grazie, Luca Cagliari, quindi c'è Salvatore, ora chi c'è a Cagliari? Oppure chi c'è? Fanos, ok, Vassilio, quindi Giovanni, anche tu Perugia, quindi 1, 2, 3, va bene. Chieti, ok. Chieti, ok. Dove volete? La Sapienza. Sapienza, Roberto Sapienza, ok. Greta Sapienza. Emma, tutti Sapienza? Ok, buono. E anche loro, non lo so. Lo sappiamo, Catania. Ok. Anna Cagliari, ok. Daria, vabbè, qua ci sono tutti raggruppati e li conosciamo. Bologna, ok. Trieste, ok. Quindi con Egidio, giusto? Ok. Trieste. Anche tu, ok, ottimo. Tutti 8 di Siena, quindi siete con Salvatore. Ma tecnicamente lo devo chiamare adesso per altri motivi. Glielo posso dire? Vabbè. Allora chi era? Solo Alberto Verrotti che non lo. Ma forse se l'è scordato, no? Se l'è dimenticato, secondo me, no? E anche Salvatore se l'è scordato, ok. No, ma era contento, non è che si è seccato. Abbiamo finito. Stiamo arrivando alla fine, quindi tutti siete Siena, però diteci i nomi. Ottimo. Genova, ok. A Genova chi c'è? Magni, ok. Alessio Genova. Perugia, anche tu allora, anche tu. E Perugia. Quindi siete tanti, lui non sapeva, lui mi ha detto credeva che fossero 1 o 2, forse non sapeva come eravate. Siamo persi. Allora. Milano, ok. Perugia. Siamo rovinati ragazzi, allora è meglio che li ritelefono. E voi? Cagliari, ok. Sono pronti, ok, ma abbiamo terminato. Brescia, Guido lo conosco, Piero ne ho bisogno. Ok. Salerno. E vi chiamate Martina? Ok, va bene. Allora, grazie, loro sono pronti. Allora, grazie di essere. Mi dispiace per Perugia, non lo dovevo fare. I called the director of the school of the postgraduate training program in Perugia, Professor Verrotti, Alberto Verrotti, and I told him there are many of your school. He said, but I don't know anything. It could be that he forgot. No. Comunque, sto scherzando, non ci sono problemi. Per la prima volta, esatto. Ma he didn't know, that's the problem. No, sto scherzando. Allora, grazie molte. Quindi loro sono pronti, ci siamo presentati tutti, grazie di essere venuti veramente da tutta Italia, questo ci fa tanto piacere e diamo la parola a lui che sono cose di sostanza. Grazie.
So maybe I'll just start off by saying, because maybe this might be the last time that we have a chance to speak to you as a group, to say it's been a privilege. It's so many levels. I'd like to thank our hosts here and Raphael and the rest of both the Italian and the Sicilian faculty. I'm not sure if I break it out that way. Like in Canada, I have to say and the Quebec and the Canadians, right? It's the same thing with the Sicilians and the Italians. So. Not really. Don't go there. Okay. But I just, we want to thank the faculty and the organizers. We want to thank the organizing group that actually helped pull all of this together. And most importantly, we wanted to thank you guys for giving us the privilege of the warm-up for Latina, right? It's interesting, every time, I think I can probably speak for Liz and Mark, every time we're getting asked questions, we're thinking, I wonder where this is coming from. This is the answer that we give now. In English, we talk about, this is going to come back to haunt us in some way. You told us in Catania that, right? So what we're going to do now is we're going to give a brief discussion on what the update on the guidelines are, the PALS guidelines from 2020, 2021. And so much of this is captured within the new the textbook that you've been using. But I think hopefully what it does is it will maybe give in a little bit more detail, a little bit of the context as to what we're teaching, and ultimately what we're testing on in Catania, where it comes from. What we do want to give credit to is these are not Mark's slides or Elisabeta's slides or my slides. These are the slides of a dear friend of ours who was supposed to be with us here in Catania, Monica Kleinman, who's a pediatric intensivist from Boston Children's. But knock on wood, she will be with us in Latina. So I'm sure that if you have any, remember on day one, I said anything you like about PALS, about the course, you can thank me. Anything you don't like about PALS, you can blame Mark, right? And then anything you don't like about the PALS update, you can blame Monica. So just remember this. And everything else, which is all good, you can thank Elisabetta for it. Okay. Okay, so what we're going to do is so as I said, these are Monica's slides, so where this comes from is that all of us are actively involved with the American Heart Association. Many of us have been either are involved or have been involved with the science review group, the International Science Review Group for Resuscitation, which is called ILCOR, the International Liaison Committee on Resuscitation. So we are all very intellectually and academically conflicted. None of us, unfortunately, none of us are financially conflicted. We are always looking for an opportunity to become financially conflicted, right? But what we're going to do is and we're going to do this as a tag team, and both Mark and Elisabetta know that they're going to jump in and add in points. I'm going to constantly be looking at them so that they'll jump in and add in editorial comments as appropriate. So what we're going to do, we're going to talk about what the recent data is around pediatric resuscitation. We'll talk about what the updates are from the 2020 and 2021 guidelines. And honestly, and I think from many of you when I met with you, and I'm sure probably Elizabeth and Mark did the same thing, with pediatric resuscitation, there's what we know, but there's even bigger holes in what we don't know, right? So these are what we call knowledge gaps, and we'll try and be transparent. I think we've all been transparent about what we know and what we don't know. So, and there is still a lot that we don't know. So, skip. So this is, I think we shared this with you. Obviously, PALS is about identifying children at risk before they end up in arrest, right? That's different than ACLS, where it's all about the adult has had the cardiac arrest on the floor, and then intervening for the adult patient who we've missed the opportunity to help. In pediatrics, it's all about identifying them early. That's when Mark went through talking about shock, and Elisabetta went through talking about respiratory failure. That's where the focus of what we do is. That's also why if you actually look at the statistics in the United States, and this is probably what we'd see in Canada as well, that you're dealing with adult, only 50% of adult cardiac arrests happen in ICU. Almost 90% of pediatric cardiac arrests happen in an ICU or in a monitored setting. So that's what we want. We can't prevent all cardiac arrests, but what we want to try and do, and the same thing what you should be doing is you want to be trying to intervene, and if you know a child is going down that path of potentially having a cardiac arrest, you're calling anesthesiology, you're calling intensive care early to make sure that you have them, ideally, you have them moved into the ICU setting before they have their cardiac arrest. As I go through this, if there's any questions or if I don't make sense, I know Elisabetta is going to make sure that she jumps in, but please stop us. This is not supposed to be death by PowerPoint. This is supposed to be having a conversation, right? Anything else that we want to, stop me as we go along, guys. The nice thing is, when we look at what we've seen in terms of results and outcomes, when forgive me for what I'm about to say, Mark. When Mark had hair on his head, and I can remember when Mark had hair on his head. All right, so when Mark and I met back around here, what's happened is we've seen survival from pediatric cardiac arrest keeps on getting better and better and better. It's still not great, right? But for out of hospital has changed a little bit. In hospital has changed dramatically. If you looked at these numbers from 25 or 30 years ago, we were talking about 15%, 15% survival from pediatric in hospital cardiac arrest. Now we're talking about survival rates of, in many centers, overall survival rates pushing 40%. So it has all of the developments in science has made a difference. As the science has changed, the guidelines change as well. And those of you that were in my group, you heard me apologizing over and over and over about I'm sorry, you're going to notice that this is going to change in 5 years' time, and it's probably not my fault, it's Mark's fault. We've talked about that over and over. But the point is the guidelines change. The science changes and the guidelines change. And I think that for a lot of these things, these are just examples. I can tell you that 25 years ago, atropine, bicarb, and calcium were used routinely in pediatric cardiac arrest. Even 10 years ago, hypothermia was used aggressively in pediatric cardiac arrest. Hyperventilation during CPR was a routine that we often saw. So many of those things have changed as we've got more science out, and as the guidelines have changed, reflecting the science. Okay, so don't get, and this is why, honestly, what we end up saying, it drives us crazy when we have colleagues that did PALS 20 years ago, and they say, hey, I've done PALS. Well, you did PALS 20 years ago, you haven't updated on the science. PALS has changed. The guidelines have changed a lot in 20 years. So it's something to be aware. The science keeps moving and the guidelines keep moving as well. Stop me anytime, guys. The chain of survival, I can't remember whether or not within Italy you guys use the same kind of chain of survival. I think in the United States, this is one of the big changes, is that survivorship or recovery has actually been added. There's another chain, another link in the chain of survival. There's a lot of emphasis on looking at quality of life of survivors, what it means for the survivor of a cardiac arrest, adult or child. How do we optimize that? That's all part. It's not just about pushing the adrenaline and giving the electricity during the resuscitation. Now resuscitation science is about how do we make sure that those children develop normally. What does quality of life look like for them? So we talked briefly on this. These are kind of where some of the major changes in the guidelines are, and we'll just go through them one by one. I think one thing is we're getting better in that if we can measure what's happening during CPR, we can measure a blood pressure, we can target what we're doing for the quality of CPR, but and we've talked about what we end up doing in terms of depth and compression rate and that. In the world that Mark and I live in intensive care, we've got an arterial line and we actually target a certain blood pressure as well, a diastolic blood pressure during CPR. I think what we do know is that the kind of resuscitation that Raphael might need and that I might need might be different. I'm 6'4", some number of pounds, right? We won't talk about it. Raphael is different. And I think what we're beginning to recognize in children, how you resuscitate and the targets and what we should do for a 2-year-old are probably different than a 12-year-old. We don't have the numbers yet, but this whole idea of one size fits all, I think, is going to change. So this is more just recognizing that the science is evolving, but what this looks like, based upon your age, your weight, your comorbidities, the kind of resuscitation you get in 5 or 10 years, probably more 10 years from now, may end up looking differently. And I think as I said, this is one of the things which we talked about in my group. We talked about the importance of diastolic pressure and driving pressure into the coronary arteries. So as I said, in our world, in Mark and my world, we're doing that all the time. We're putting in arterial lines, and we know that if we end up hitting a diastolic pressure of 25 in infants or a diastolic pressure of at least 30 in older children, that their outcomes are better, and we target that. Now, if you're on the pediatric ward or in the emergency department, you may not be able to measure those. But still, I think we're looking at targets. The only way that we can get better is if we measure something. So I think that's new. That's the targets of resuscitation probably do need to be different. Ventilation rates, we talked about this whole idea that it's no longer 10 breaths a minute when you've got an endotracheal tube in, and it's now a breath every 2 to 3 seconds, so a ventilation rate of 20 to 30 breaths per minute. That's new science. Now, it's not the greatest science, but it's some pediatric science. This whole idea of 10 breaths a minute had been adults and children for at least the last, I can think back, 30 years, right? And it really wasn't based on any data. At least now, it's not the greatest data, but we've got pediatric data that actually suggests that if you're an infant, you need to have 30 breaths a minute for best outcomes, for likelihood of survival. And if you're a child, you need to have at least greater than 20 or 25 breaths. So that's science. Science is there. The guidelines are evolving. Hopefully, outcomes are going to get better as well. And that's now reflected in the resuscitation guidelines that we went through over the last 2 days. Intubation. I don't know, Elizabeth might have talked about this in respiratory, but I think this whole idea of, we know for respiratory failure, we talk about there's a role ultimately for some children to secure their airway. For children in cardiac arrest, you'd think that of course we should be putting a tube in. We should be putting a laryngeomask airway, we should be intubating them. But it's interesting, there is actually data that shows, and this is all observational data, but it shows that if you actually do an adjusted analysis and you try and adjust for all of the confounders that involve pediatric cardiac arrest, that what happens is that the likelihood of surviving if you're intubated or have a supraglottic airway placed are actually worse than if you don't have the airway placed. Now, why is that? Is it the pauses in ventilation, or sorry, the pauses in compression to get the endotracheal tube in? Is it the effect of positive pressure ventilation with the tube in? I don't know, we don't know, but the bottom line is that I think here's the reality. We, in a kid in cardiac arrest, eventually we need to put a tube in. We can't keep on bag, mask ventilating them forever. But I think, and I'll look to Liz or to Mark and say, you guys tell me your threshold, how many minutes into your, if you have a patient that's not intubated already, how many minutes, when do you put the tube in? Liz? 5 minutes, Mark?
No time. I mean, as long as we're moving the chest and there's no.
So maybe longer than 5 minutes. And it used to be with us, it would be like, yeah, the patient's in arrest, we're automatically getting someone to put a tube in. With this kind of data, it's kind of like, ooh, maybe we have to eventually for kids with longer arrests, but maybe what we need to do is we need to delay it. We talked about, yeah.
There was a discussion about the LMAs and how LMAs are a really nice option. So, you know, Alan, I don't know if we want to stick with a definitive time, you know, for our PALS cases of when you would want to put an LMA, but this came up a lot. So we definitely talked about not wasting time intubating, because you would never intubate anyways as pediatric residents in your settings. But if you are in a setting that you would use an LMA, I think it's a very reasonable thing to do and to practice and to consider, and we will have them in the PALS stations. So that was a topic that came up a lot, and that would be a nice alternative, an easy alternative.
You know, and that's so, and building on that, we talked about why, you know, at least if you have an LMA, you can do uninterrupted compressions. You can, if you have the ability to monitor an end-tidal CO2, you can provide higher quality chest compressions. The sad reality, and Mark and I live this now, the sad reality, I don't know how we go backwards. Oh, there we go. If you go backwards, and I won't get you to look through this, but the data from the same big systematic, or this great big registry study showed that whether you were intubated or you actually had a supraglottic airway, there was no benefit to either. Mortality was worse with both. So once again, is that positive pressure? What is it? And I think your decision around, do you put a supraglottic airway, an LMA in, or do you not? We don't have great data, and at the end of the day, you're going to have to, honestly, I think if it allows you the ability to do continuous compressions and to monitor end-tidal CO2, then we should be doing it. But just so you're aware, there's actually people that push back and say, you know what? You're just as likely to kill the patient with an LMA as you are with an endotracheal tube. It's tough. Sometimes the science makes it more confusing for us, all right? Time to epinephrine, we talked about this in the cardiac arrest station. There is great data now that shows us that earlier is better, that epinephrine in the first 5 minutes is really important. And I think that's, for pulseless for cardiac arrest that is not shockable, the same way that we for many years have talked about electricity as being time sensitive, now for non-shockable rhythms, epinephrine, adrenaline is time sensitive. We need to get that. So when I identify, in fact, if I've got enough nurses and doctors with me, when I'm starting the resuscitation, I'm not waiting for the rhythm to decide whether or not I'm going to draw up the epinephrine. I'm drawing up the adrenaline as soon as I can, because whether it ends up being shockable rhythm, I know down that algorithm, eventually I'm going to need adrenaline. I know if it's non-shockable, I'm going to need adrenaline right away. So either way, if you've got someone there, draw up the adrenaline as soon as you can. You're going to need it. So time is, what's the expression? Time is brain. Time is brain. Yeah, that was for you. The neurologist. I said time is brain. So, and it's not just a matter of what the timing is. There is data that's coming out that's actually a little, it's kind of scary, that shows where for our long cardiac arrests, frequent doses, maybe too many doses of adrenaline actually worsen outcome as well. And really so this whole question of do we end up giving adrenaline every 3 minutes, every 4 minutes, every 5 minutes, every 8 minutes? Right now, as we know, we give it every 3 to 5 minutes. And in many of our worlds, we just say, hey, we'll give adrenaline every 4 minutes, right? But is there a role to actually give less frequent adrenaline? In my world, probably in Mark's world as well, the reason we're giving adrenaline is to keep the diastolic pressure high. If I'm keeping the diastolic pressure high and I'm at 5 minutes after the last dose of adrenaline and I've still got a diastolic pressure of 60, maybe I don't need to give another dose of adrenaline. But the guidelines and the PALS course say, and what we're going to be looking for in Latina, right, is that still adrenaline is every 3 to 5 minutes. But all I'm saying is the science is evolving and it's becoming more and more confusing. Okay? Therapeutic hypothermia. So we were putting lots of kids on ice. We were cooling them after cardiac arrest, and we were jumping on with some early adult data. What's happened is now we have pediatric data, and it's studies that are called the THAPCA studies, THAPCA. Bottom line is that whether it's for in-hospital or out-of-hospital cardiac arrest, what we've ended up seeing is that whether you cool the patient or you keep normothermia, keep a normal body temperature, there's no difference in outcome. So after we get the patient back, as we're moving the patient to an ICU, we don't want them to have fever. Fever is bad after cardiac arrest. But putting them to a temperature of 32 degrees instead of keeping them at 36, there's no advantage. So, or at least we think that there's no advantage. So the guidelines and what most of our practice would be, we don't cool patients to try and have a low body temperature anymore. Questions as we're going through this? Everyone's just thinking of lunch. Okay. So we talked, there were some really good questions about, so we do a cardiac arrest, what do we do after resuscitation? And I think a lot of the time we actually haven't done a good job of teaching what post-resuscitation care, post-cardiac arrest care should be. We are now, there's data coming out that's showing that how we look after these patients after cardiac arrest makes a huge difference. Allowing hypotension is bad. Survival of kids after cardiac arrest, if we allow their blood pressure to be too low, is bad. So we give them some fluid, we give them epinephrine, norepinephrine. So some of these things, there's a lot of science that's coming through. How do we breathe for them on a ventilator? What do we do when it comes to how do we monitor or treat for seizures? There's your neurology piece, right? So there's a bunch of the science is evolving, but as important as cardiac arrest care, post-cardiac arrest care is really important as well. So just to leave it, so I think what we've done, hopefully what we've been able to do, we've left with you that guidelines change, the science changes as well. In pediatrics, we've got very few randomized controlled trials. Most of the science that informs our guidelines are actually from small observational studies. And I think you do have to be careful. Where historically, often what we've done is we've said, hey, the adults are doing this, we'll just jump on board and we'll do it with the adults. That's what we did with hypothermia. In retrospect, those were bad. There were bad things that we ended up doing. So the point ends up being is that ideally what we need is we need pediatric data, which is actually going to help fill in these knowledge gaps. And heavens to Betsy, we know that there are a lot of these things that we've got some data on, but we don't know how best to use some of these tools surrounding the care of children that have cardiac arrest. So these are still things that are controversial. What's the best way to predict and prevent cardiac arrest? I don't know if you guys end up using early warning scores or rapid response teams in children's hospitals in Italy, but are there ways that we can actually identify children early to prevent them from going into cardiac arrest? We talked about ultrasound and POCUS. What's the role of POCUS during cardiac arrest? Does it change what we end up doing? If we see the heart beating, so what? On the other hand, if we see a big pericardial effusion, that is important during cardiac arrest, right? But what is the role for it? If we end up having things such as ECMO, where we can put patients on cardiopulmonary bypass, if we have that technology, who are the children that we should be doing it for? When should we be doing it? And then, really importantly, if the kids go into your intensive care units, what do we use to decide, and how long do we wait to decide whether or not we should continue treating those children? If all we're going to be doing is treating them for days and days and days, and they're going to have a very bad neurologic outcome, maybe doing all of that early on was the wrong thing to do. But on the other hand, making decisions without the right tools to have a prognosis and withdrawing life-sustaining therapy early is not the right thing to do either. So I think we're still working on trying to figure out what's the best tool or group of tools to use to decide how long should we keep on using or supporting the kids after cardiac arrest. Does that make sense? All right. And that's, for what it's worth, that's Monica. When you see her in September, she is all about baseball. What's the name of the baseball field in Boston? Fenwick Park, right? So this is all about Boston. Anyway, we're happy to answer any questions that you folks might have.
Thank you very much. I think that the baseball team called Sox.
Yeah, Red Sox.
Boston. Red Sox. I'm sorry because they. Ok, allora, dimmi professor Ruggeri. Ah no, mi chiama no. Allora, Antonio, vieni qua con me. Allora, altre due chicche vi diamo, perché poi abbiamo. Ora facciamo una foto insieme. Ne facciamo due tipi di foto per
Prima voi distribuirete i soldi a ciascuno di voi da parte sua.
certo, distribuirò qualcosa, non so, soldi non è detto. Qualcosa, soldi lo dice. Allora, una foto la facciamo tutti insieme, ok? Tutti insieme tutti. E poi ne faremo una fuori e vorrei che si capisse no? Quando siamo concentrati e quando siamo un po' più relaxing, ok?
Allora, io innanzitutto voglio ringraziare i nostri ospiti perché in realtà fanno parte della famiglia. Martino, grazie. Grazie ai fratelli Luca, Piero e quello che non c'è, oltre a noi Riccardo, quindi Raffaele è il padrone di casa. Abbiamo parlato in questi giorni facendo poi il punto su quelle che sono le realtà nostre, le evidenze scientifiche, i dubbi che ci vengono, specie ai nostri amici neonatologi, lo diciamo spesso, che l'asticella la stanno abbassando al punto che poi i residui neurologici sono sotto gli occhi di tutti, ma abbiamo parlato di noi, di come lavora l'equipe. Non ci siamo quasi mai interessati a quello che è l'aspetto, l'altro, quello del paziente, quello della famiglia dei pazienti. Allora vi voglio leggere una cosa che ha scritto, non so se conoscete Maurizio De Giovanni, che è uno degli autori che amo di più, che ha avuto la sfortuna, l'evento tristissimo di un infarto importante, e lungo il viaggio, nel suo viaggio in auto per arrivare in ospedale, chiaramente ha rivisto tutti i personaggi della sua mente, e voi lo sapete, delle volte Maurizio De Giovanni diventa non prosa ma diventa poesia, e poeticamente ha raccontato questo viaggio verso l'ignoto, verso la morte. Alla fine, superato il momento, perciò voglio farvi capire quanto è interessante l'ottica dei pazienti quando vedono un'equipe che lavora in un certo modo. E allora ve lo voglio dire con le parole che ha usato lui. Innanzitutto, dopo gli eventi che gli erano successi, arriva in ospedale e trova un angelo che immediatamente, quello che è stato detto fino adesso, col colpo d'occhio in 20 secondi dice codice rosso e allerta la sala rossa per far arrivare il paziente infartuato, che ormai già non era più tra di noi ma stava tra i suoi personaggi. E lui dice, l'infermiera geniale diceva codice rosso, avendomi solo guardato in faccia da 20 metri, mentre si completava il viaggio verso un luogo di assoluta eccellenza e professionalità, mentre attorno a me ognuno sapeva con esattezza quello che doveva fare, in una coreografia perfetta che era un inno alla competenza. Mi chiedevo il perché dell'assenza della paura. Lui sta morendo, sta insieme ai suoi personaggi e vede che c'è una coreografia di persone con il cappellino verde, con il loro completo verde, che come se danzassero intorno a lui, facendo ognuno tutto quello di cui vi hanno parlato i nostri amici del lavoro di equipe. Urlare quando arriva questo, mi manca questo, sono degli aspetti che non ci rendiamo conto quanto alle famiglie, al personaggio che stiamo, alla persona che stiamo assistendo in quel momento, tolgono ogni possibilità di speranza, mentre invece lui in questo momento paura non ne ha. E continua: avvertivo piuttosto una strana malinconia, una specie di assurda nostalgia del futuro, un senso di cose perdute, un vago scrupolo, come quando ci si addormenta vinti dalla stanchezza, avendo ancora qualcosa di importante da fare. E dietro le file perfette di camici verdi e delle mascherine e dei cappellini, sotto il grande schermo sul quale il professore studiava i flussi e le barriere da abbattere, ho intravisto un gruppo di spettatori interessati, su cui volto c'era la mia stessa nostalgia triste, e vede i suoi personaggi, questi ve li salto, alla fine, e vede chiaramente il commissario Ricciardi, no? Con l'occhio molto penetrante, l'occhio azzurro penetrante, che sa che lo sta accompagnando verso una fine completa. In quello stesso momento il professore ha detto: ecco qua, tutto a posto, e il cuore ha ripreso a battere. Grazie.
Bellissimo, 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 bellissimo. Era sicuro, un po' come la mamma, quando vede che insomma ha persone davanti che non sanno quello che fare, eccetera, invece ti senti accompagnato, accudito, con certezza. Bellissimo. Foto? Foto? In which position? No? No. No. Cioè noi siamo qui e la foto... E quindi come la facciamo? E quindi... Tutti qua dietro. Vabbè, allora, e come facciamo tutti qua, abbassiamo il Covid e aumentiamo. No, scherzo, ormai. Venite tutti qua, facciamo la foto tutti qua. Venite tutti quanti qua. Tutti. Non so come faremo, però tu la vuoi fare la foto? Tutti. Dov'è il professore Ruggeri? Anche dietro. Anche tutti ragazzi, mettetevi come volete. Aumentiamo lo spazio. No, aumentiamo lo spazio. Elisabetta.
Secondo me si spezza sto coso.
Aumentiamo lo spazio. Aumentiamo lo spazio. Ancora. Aumentiamo lo spazio. Forza dottoressa Portà, dottoressa, lei dottoressa. Venite, tutti i team leader, tutte le mamme, i papà, le dottoressa, le osse, le infermiere che hanno simulato, chi ha simulato la mamma, ha simulato il papà, anche a terra se volete, in ginocchio a terra sì, no, vi dovete... C'è come... Tutti in basso. Anzi, ma vi vedete voi? Chiara, li vedi loro? Tutti devono, non c'è essere un viso che non si vede, ce la fate? No, li vedi loro? Io mi abbasso, io sono molto alto, però. Manca qualche viso? La Pasquetti, c'è il viso da Pasquetti? Tutti bravi! Al lancio!